Good morning, ladies and gentlemen, dear teachers, colleagues, and trainees. We welcome you all to yet another specialty day organized by the Ceylon College of Physicians. And we thank all of you for joining us on a Sunday morning. And today we indeed have a lineup of presentations on the subject on maternal medicine. And without much ado, we will go on with the proceedings. Of course, I would like to give some housekeeping announcements. We will have this session going online, and thereafter we will be making this available through our portals for you to go through later on. You can post in your questions through the chat box, which I will be moderating at the end. Let's get on with our program. So we first have a talk on hypertension in pregnancy, a change of paradigm of hypertension in pregnancy. And this will be delivered by Dr. Carmelin Mota. She is a consultant physician and a senior lecturer attached to the Faculty of Medicine, University of Kelaniya. Over to you, Dr. Mota.
Thank you, Shehan. I would like to thank the Ceylon College of Physicians for inviting me to talk on a very timely topic, especially given the fact that hypertension in pregnancy remains an important cause of maternal morbidity and mortality, not just locally, but worldwide. I will first talk about the recent advances in managing hypertension in pregnancy, keeping in line with the subject of my presentation, followed by the physician's role in managing hypertension in pregnancy. As you are aware, it's our obstetric colleagues who mainly deal with managing hypertension in pregnancy. It's an area that's heavily guarded by our obstetric colleagues, and they do a wonderful job in doing so. But there are instances when we as physicians are called upon to manage these women. What are these instances? And that is what I'll be addressing in this section. And finally, I'll share with you a few words of wisdom in order to avoid some common pitfalls in management. Getting on to recent advances in managing hypertension, with regard to target blood pressure. Now, up until recently, the target blood pressure was considered 150/100 or moderate hypertension. Mild hypertension was not treated, and this was based on the pathophysiology of hypertension in pregnancy and preeclampsia. Treating mild hypertension was considered to further impair the uteroplacental blood perfusion and cause disastrous consequences to the fetus. However, a landmark trial that was published recently, the CHIPS trial, Control of Hypertension in Pregnancy, which was conducted by Maggie and her colleagues, which was an open, multi-center international trial involving about 1,000 women, which was published in the NEJM, changed this practice. They looked at less tight versus tighter control of hypertension. Less tight was defined as a diastolic blood pressure of 100. Tight control was a diastolic blood pressure of 85. And the primary outcome, which was fetal death and neonatal admissions more than 48 hours in the neonatal unit, surprisingly did not change. However, the rates of severe hypertension was significantly different. It was 40% in the less tight group compared to 27% in the tighter control group. And we know that the severe hypertension can cause harmful effects like intracerebral hemorrhage and pulmonary edema if not controlled adequately. And this changed the cutoff values for hypertension in pregnancy, and the latest NICE guidelines, which was published in 2019, brought down the blood pressure values, and they recommend to treat blood pressure if it exceeds 140/90, and they recommend the target blood pressures to be 130/85. So this was a significant change in the guidelines. What else is new? The categories of hypertension have now been simplified to hypertension and severe hypertension rather than mild, moderate, and severe. And the latest NICE guidelines no longer recommend a 24-hour urine collection to quantify proteinuria, but they recommend urine protein creatinine ratio or the urine albumin to creatinine ratio, which they consider to be more accurate and reliable. Up until recently, all women with preeclampsia were recommended to get admitted, but now a risk assessment should be carried out and an individualized approach should take place instead, and only women with certain risk factors are uh, expected to be admitted. So these are some of the changes and recent advances that have come about. Everyone talks about a higher limit for blood pressure, but what about a lower limit? The 2019 NICE guidelines talk about a lower limit for women with chronic hypertension. They say that in women who are on treatment for chronic hypertension, to continue with existing antihypertensive treatment if it is safe in pregnancy, or switch to an alternative treatment unless the sustained systolic blood pressure is less than 110, or the sustained diastolic blood pressure is less than 70, or the woman has symptomatic hypotension. So this is a big step forward in the right direction. And this is something we need to reinforce to obstetric colleagues, to have a lower cutoff value for blood pressure, or else the uteroplacental perfusion is going to drop and there's going to be fetal compromise. And the American College of Obstetricians and Gynecologists had already endorsed targeting the diastolic blood pressure above 80. At least 70 millimeters of mercury should be the cutoff value. And we need to reinforce this and have a lower limit for the blood pressure. So please keep this in mind when treating women with hypertension in pregnancy. Now, over the last several years, there have been a lot of research uh, with biomarkers to predict preeclampsia, which is the killer when it comes to hypertension in pregnancy. Though there have been several studies that have been done, none of the biomarkers have been shown to predict preeclampsia reliably in clinical practice. Nothing has been brought forward for us to use in clinical practice, and nothing has been brought to guidelines up to date. However, Chappell and her colleagues in the United Kingdom, this study changed the practice, and her study concluded that in women presenting before 35 weeks, that with suspected preeclampsia, low placental growth factor had high sensitivity and a negative predictive value in for preeclampsia in the next 14 days or 2 weeks, and is better than currently used tests. Following this study, a few other similar studies were performed, and the 2019 NICE guidelines recommend to offer placental growth factor-based testing to help rule out preeclampsia between 20 weeks and up to 35 weeks of pregnancy if women with chronic hypertension, who are the group of women at highest risk of developing preeclampsia, are suspected of developing it. So here is another landmark, another important development in the for us, where we have a biomarker that can predict preeclampsia, and if this is positive, very close surveillance can be carried out, and we can reduce significant morbidity and mortality both in the mother and the fetus. And this has come into the guidelines, which we can now put into practice. Hypovitaminosis D in adult medicine is a hot topic these days, and it has also encroached into obstetric medicine. Most of you may be aware that women pregnant women who are deficient in calcium in their diet, when repleted or given calcium, adequate calcium, the rates of preeclampsia have been shown to reduce. Researchers went a step further and looked at vitamin D levels and preeclampsia. And they found that women who have low vitamin D levels had a high risk of developing preeclampsia. These are some of the well-powered studies in the recent past that have shown this association. This systematic review, which was published recently, however, showed this association, but when they looked at vitamin D supplementation and the risk of developing preeclampsia, disappointingly failed to show a positive benefit. Therefore, further studies need to look at the exact link between vitamin D levels and preeclampsia, and further studies are underway to look at this. Getting on to the second topic that I wanted to discuss, the physician's role in managing hypertensive disorders in pregnancy. The first area that I want to discuss is severe hypertension. Now, this again is very well dealt with by our obstetric colleagues because they are very experienced in managing this. This is not uncommon in clinical practice. But let me take a scenario. Let's take a woman who comes with a blood pressure of, say, 270 over 160, and there's fetal distress. And the obstetricians are not sometimes that patient, and they want to deliver the baby immediately, and the anesthetist doesn't want to touch the woman because the risk of postpartum hemorrhage is high. And the obstetrician is quite agitated and will call upon the physician to bring down the blood pressure fast. Now, unfortunately, we have only a few drugs to play around with when it comes to severe hypertension. These are the first-line drugs. But if we know the pharmacodynamics, we can achieve what we want to. Labetalol, as you know, can be given intravenously as a bolus. The usual starting dose is 20, but remember you can go up to a maximum of 80. But remember that you can repeat it every 10 minutes. Nifedipine, though an oral drug, is very potent. The usual dose is 20 milligrams, but you can go up to a maximum of 40. But you have to wait for about 45 minutes for you to repeat it. Hydralazine, again, can be given intravenously, but you have to repeat it only you can repeat it only after about 20 minutes. But you can go up to a maximum of 30. So what you can do is, you can start giving intravenous bolus of either labetalol or hydralazine. At the same time, give nifedipine orally, so that it acts synergistically. And usually you can achieve what you want to. The other drugs that can be given for severe hypertension is diazoxide intravenously. And if you really want, you can give GTN intravenously, as well as sodium nitroprusside. But sodium nitroprusside, remember, can release cyanide, and there can be fetal toxicity. So just before delivery, you can give it if you really want to, but knowing very well that there can be effects to the fetus. But in very rare instances, you can use it. But these are the first-line drugs, and generally you can manage quite well with this if you know the pharmacodynamics. I would like to share with you 2 case studies to illustrate some of the complications of severe hypertension, mainly preeclampsia. A primigravida who delivered following severe preeclampsia a day ago complains of progressively worsening blurring of vision and severe headache. Her blood pressure is 150 over 100 while on captopril and nifedipine. What is the likely cause of her symptoms? Now, here is a woman delivered 1 day ago due to preeclampsia, but complains of progressively worsening blurring of vision and severe headache. A little bit unusual. Once you deliver, you expect the blurring of vision to get better and the headache. Any guesses? Posterior reversible leukoencephalopathy. I'm sure you've heard of this. This is not something that is unique to pregnancy. It can occur outside pregnancy. What is this? Now, cerebral autoregulation is supposed to maintain cerebral perfusion independent of fluctuations in systemic blood pressure. This is ensured by cerebral vasodilatation at times of systemic hypotension and cerebral vasoconstriction at times of systemic hypertension. But when a patient's blood pressure goes above this the cerebral autoregulation, then there is cerebral hyperperfusion and vasogenic edema. And it's the posterior part of the brain that is particularly susceptible to this because there is reduced sympathetic innervation compared to the anterior part of the brain. And this is the typical picture that you see on an MRI scan of the brain, which is the imaging modality of choice. And the patient classically presents with this headache, seizures, visual abnormalities that can take the form of lateral gaze palsies as well as cortical blindness and altered mentation. And this is one of our patients who presented with severe preeclampsia at 32 weeks, HELP syndrome, impaired renal functions, and the obstetrician very correctly delivered her on time. Everyone was relieved, and the next day she complained of blurring of vision, and to everybody's dismay, had this right lateral rectal palsy. Urgent MRI was done. All she had was posterior reversible leukoencephalopathy, and it was the cerebral edema that was probably responsible for this, the severe cerebral edema. Several weeks later, she completely resolved. What is the treatment for posterior reversible leukoencephalopathy? It is the meticulous control of blood pressure, and that only. And very importantly, to reassure the patient, and more importantly, to reassure the obstetrician. So this is just to illustrate how hypertensive disorders can present in less conventional ways. My second case study is a woman with severe preeclampsia who delivered and complained of shortness of breath and orthopnea on the first postpartum day. Examination revealed tachycardia, tachypnea, bibasal fine crypts, and hypoxia. So the obvious diagnosis was pulmonary edema. However, the echo was normal. So then, what was the diagnosis that we had to entertain? Non-cardiogenic pulmonary edema. So in women with preeclampsia, remember that there is endothelial dysfunction, much like what happens in dengue hemorrhagic fever. There is leakage of fluid into the alveoli. So all you need to do is prop up, give oxygen, and give IV diuretics liberally. And that you can do in the postpartum period without any problem. And you see a dramatic improvement in 1 to 2 days' time. Now the next area that I want to talk to you about where the physician has a role is the postpartum period. And I would urge you to get involved in this area, which is an important aspect, and I will tell you why. The blood pressure target during the postpartum period is 150/100, and we have a few more drugs that we can use. Remember that it's best that if you can use a drug that could be given once daily because the woman is breastfeeding and it is convenient for her. Enalapril is preferred therefore over captopril, but it's not readily available in the state sector. If one drug cannot control the blood pressure, then you obviously need to combine, so enalapril or captopril, nifedipine or amlodipine. So step 2 is a combination of one of the above, and step 3 is either atenolol or labetalol, a combination. Now, postpartum hypertension is very important. However, there's very little data, obviously, because once women are discharged, they don't come back for follow-up because they need to take care of a newborn baby. So there's very little literature worldwide. But one of the few prospective studies that is published is by Goel and his colleagues, where they looked at 1,000 women, and some very interesting data is available, where he found that among the women who were normotensive before delivery, 10% developed new or de novo hypertension postpartum. And among the women who already had a diagnosis of hypertension before delivery, 50% continued to have hypertension in the postpartum period. But mind you, this included women who had pre-existing hypertension. And the majority of patients develop postpartum hypertension between 42 to 72 hours following delivery, not in the first 2 days. And nearly all patients developed hypertension within the first week. And we do see this in our practice too, where this corresponds to the time during which the extracellular fluid relocates back into the vascular space. Now, this data is very useful and important to us because this is compounded by the fact that pregnancy is a hypercoagulable state, the risk being greatest in the puberia. Sorry, the risk of thrombotic events substantially increases within the 6 weeks postpartum and normalizes after 12 weeks postpartum only. And the majority of pregnancy-associated strokes occur in the first 48 hours after delivery, and hypertension is the strongest risk factor. And studies have shown that cerebral infarction and intracerebral hemorrhage is high in the postpartum period. The take-home message is very clear: look for and treat postpartum hypertension adequately. Very often, once a woman delivers, blood pressure is not checked in the wards. And the study that I showed you very clearly showed, and few other studies have shown, that the blood pressure comes back to normal in the first 2 days. It goes up only after 48 to 72 hours. We need to tell obstetric colleagues this very clearly. Don't discharge the patients until 48 to 72 hours. The blood pressure can go up only after that. Keep the patient for at least 48 to 72 hours. Secondly, once you discharge the patient should be very clearly told, both verbally and written in the diagnosis card, if the blood pressure goes beyond a certain value, to come back immediately. And at 6 weeks, there should be a definite review. The data that I shared with you also showed that de novo hypertension can occur for the first time postpartum. So all women, irrespective, even women who did not have hypertension antenatally, should check their blood pressure postpartum, preferably weekly until 6 weeks. Why is postpartum hypertension common? The study that I shared with you, NSAIDs were used in 90% of women. Please avoid NSAIDs in the postpartum period. American College of Obstetricians and Gynecologists discourage NSAIDs in patients diagnosed with hypertension. Another important area, women who have had hypertension and whose hypertension has resolved completely postpartum, there's evidence to say that the risk of future hypertension, cardiovascular, cerebrovascular, and chronic kidney disease increases in the future. And this was our own data, which we presented in the Netherlands 2 years ago, where we found that women who had hypertension, the risk of future hypertension, ischemic heart disease, stroke, diabetes, and metabolic syndrome was significantly greater. So the take-home message is that women who had hypertension but resolved completely postpartum, that they should have an annual screening of blood pressure, lipid profile, and blood sugars. Few words of wisdom that I'd like to share with you finally. Remember that serum creatinine decreases in pregnancy, and the upper end of the normal range indicates impaired renal function. And in women with preeclampsia, oliguria may occur and should be considered physiological. Fluid therapy should not be given unless the serum creatinine is rising. And in women with severe, very early onset preeclampsia, I'm talking about women who have preeclampsia occurring at about 26 to 28 weeks. Look for features like SLE, underlying renal disease, or antiphospholipid syndrome, especially if there is underlying clinical features. And remember that somebody who delivers due to preeclampsia before 34 weeks, that itself is a clinical criteria for antiphospholipid syndrome. This will easily slip off the obstetrician's mind, but as physicians, we need to remember to refer to a hematologist. What is the future in the field of hypertension in pregnancy? American College of Cardiologists redefined blood pressure targets in adults. Will the same happen for our women? Reddy and his colleagues did this trial and looked at lower blood pressure targets for women in pregnancy, and they found that preeclampsia and its adverse outcomes are seen at blood pressure targets below 140/90. So in the near future, it looks like blood pressure targets will be redefined in pregnant women too. That's all I have to say. This is a flower which is the snowdrop, which symbolizes hope. I have put this for a reason. Let's hope that the paradigmal shift brought about by the new advances in the field of hypertension in pregnancy will bring about a better outcome for our mothers and their babies in the not too distant future. Thank you.
Thank you, Madam, for that excellent presentation. We would like to invite our viewers to pose in questions through the chat box. There is one question that has come up. A listener is asking, the national guidelines suggest that high-dose calcium is advocated antenatally. You spoke of vitamin D. What is the effect of calcium with regards to hypertension in pregnancy?
So I would like to say that what the evidence has shown is that calcium is given for various reasons in pregnancy. One is because the mothers need adequate calcium in order for preparation for lactation. But the other important reason is to prevent preeclampsia. But what evidence has shown is that in order to prevent preeclampsia, you need at least 1000 milligrams of calcium. But most of the time, what is given in as antenatal supplementation is not 1000 milligrams, but a much lesser dose. It's 500 milligrams. So I think our antenatal guidelines should really the 500 milligrams is adequate for in order for as a supplement for to prepare the mother for breastfeeding, but not as to prevent preeclampsia. So I think this is something that we should look at actively, and our antenatal program should really take this forward and should recommend an increased dose if we are to prevent preeclampsia. We have not started.
What is the effect of aspirin, especially in people who are prone for abnormal glycemia in prevention of hypertension and preeclampsia? Yes.
In women with abnormal glycemia.
Yes.
And preeclampsia.
Yeah. Yes.
Yeah. So aspirin prophylaxis is given at a dose of 150 milligram in women with high risk factors for preeclampsia. But you're also asking with abnormal glycemia. So in type 1 and type 2 diabetic women, aspirin prophylaxis is advocated because they're at high risk of developing preeclampsia, but not in women with gestational diabetes mellitus.
Thank you so much. In the interest of time, we move on with the next presentation. Thank Dr. Mota for being with us this time. Our second presentation is based on dermatology, and the title of it is Dermatosis in Pregnancy, Evaluation of Significance. And we have with us, we thank Dr. Chalukya Gunasekara for being with us at this time. Dr. Chalukya Gunasekara needs no introduction, but she is the senior consultant dermatologist at the National Hospital of Sri Lanka and has been a trainer to many of us. And over to you, Dr. Gunasekara, for your presentation.
I'd like to start off by thanking the Ceylon College of Physicians for organizing this specialty day and inviting me to be part of this activity. So, pregnancy is meant to be a joyful time for an expectant mother. However, the majority of females experience some cutaneous change during their pregnancy. And this can have a huge impact on the expectant mother in terms of annoying symptoms like pruritus, or even the psychological impact it can have due to the ugly rashes that can come up. And of course, the mothers will always worry whether this could have an impact on their unborn child. And these cutaneous changes are brought about by mainly the endocrine changes of pregnancy, However, metabolic changes as well as, interestingly, the change in the immune status of the female also has an impact on this. Next slide, please. All right. So, during pregnancy, due to the presence of pregnancy hormones, namely progesterone and estradiol, there is a tipping of the balance of the immunological status of the pregnant female towards a Th2 cytokine profile, which means that there is more IL-4, IL-5 production, and there is inhibition also of the Th1 cytokine profile, such as the production of TNF-alpha production. Now, could these physiological changes meant to protect the fetus from the immunological attack by the mother's immune system? However, these can have significant implications on uh, pregnancy dermatosis. So when we look at a patient presenting with cutaneous changes in pregnancy, we need to always keep in mind that this could be a rash which is completely unrelated to pregnancy that anybody can develop at any time of their lives. On the other hand, there are some pregnancy related conditions. The first thing to exclude, of course, would be any physiological changes which could take place in pregnancy, which could be mistaken for a rash. Then there are the pregnancy specific dermatoses, and some of these are associated with fetal risk, which are the ones we would worry about. That is pemphigoid gestationis and intrahepatic cholestasis in pregnancy. And there are those which are quite benign without any fetal risk, atopic eruption in pregnancy and polymorphic eruption of pregnancy. Then also there are some effects on pregnancy, uh, of pregnancy on pre-existing dermatological conditions as well. So let's go into the physiological changes during pregnancy. The commonest change that the majority of females experience is hyperpigmentation. And this is related to elevation of MSH as well as the pregnancy hormones. Most people develop just a generalized mild hyperpigmentation, which is accentuated on certain body areas like the areolae, nipples, and inner thighs. And we all know about the linea alba, which stretches from the umbilicus to the pubic region, which turns dark and is referred to as a linea nigra. Melasma. This can be quite distressing to a young pregnant female in the prime of her life because it's visible to everybody. It's also called the mask of pregnancy or cloasma of pregnancy, and is reported in a significant number of females. Again, related to elevated MSH. Uh, the good news is, of course, that this would resolve postpartum, however, could recur in subsequent pregnancies and with the use of uh, oral contraceptives as well. You recognize melasma by the light hyperpigmentation that is seen on mainly sun-exposed areas with shaggy geographical borders. Unfortunately, we cannot use some of the agents that we use for melasma, namely depigmenting agents, which are contraindicated in pregnancy. We manage these patients with milder local applications and avoidance of sun exposure with the use of sunscreens. There are hair changes. Some females experience hirsutism, which usually regresses 6 months postpartum. What is more commonly seen is telogen effluvium. Actually, what happens is with the anabolic status of a pregnancy, there is retention of hair which was meant to be shed routinely. And therefore, they will have a fuller head of hair during pregnancy, and soon after partus, this hair starts shedding. And this can be quite protracted, can last a couple of months, and can be very distressing to female in the postpartum period. Some females experience androgenetic alopecia with regression of the frontoparietal area, but this is not so common. Nail changes can occur, not so common, not a big issue, and usually reverse following partus. There are some interesting changes in the function of glands. There is an increase of the eccrine sweat gland activity. And this can contribute towards excessive sweating experienced by a lot of pregnant ladies, and also can promote a lot of sweat rashes, and also uh, a lot of fungal infections, especially in a tropical country like ours. Actually, Sri Lanka is going through an epidemic of tinea infections at the moment. They are having a lot of extensive and resistant tinea infection, and this can get further promoted due to sweating during the pregnancy period. Also, added to that, we cannot use some of the oral, we cannot use actually oral antifungals during pregnancy. We have to manage with topicals, and this also can lead to further spread of these infections. Uh, Also, during pregnancy, the sebaceous gland activity increases, as well as there can be hypertrophy of sebaceous glands, and this is particularly noted in the areola, and referred to as Montgomery's glands. So sometimes people get worried thinking these are warts, and they come, and you can easily reassure them. The good news about apocrine function is that there is some reduction in the apocrine function activity, and therefore conditions like hidradenitis suppurativa usually are not a problem during pregnancy. Regarding connective tissue changes, striae are of course the change that the majority of females experience, and this starts towards the 6th or 7th month of pregnancy. Both hormonal factors, the presence of steroid hormones in the circulation, as well as just physiological stretching of the skin play a role in producing striae. And after practice, these usually turn into a more sort of a whitish atrophic kind of striae, but do not go away completely in most females. Uh, Management is actually best by prevention as much as possible. Emollients form the mainstay of trying to minimize striae, but it is also thought that if there is a genetic tendency to develop striae, so you cannot prevent it 100% even with these topical applications. There are a lot of vascular changes with the hyperdynamic status of the female during pregnancy. Spider angiomas or spider nevi, as some people refer to, are very common in pregnancy, and sometimes these can be mistaken for vasculitis, and they may undergo unnecessary biopsies and further evaluation for vasculitis when it can easily be diagnosed. Spider angiomas usually disappear on blanching. Also, you can get palm erythema, as well as a variety of other vascular changes, including precipitation of hemorrhoids in pregnant females. Uh, Going on to pre-existing dermatoses in pregnancy, once again, due to this interesting changing immunological status, a lot of infections can get activated during pregnancy, such as candidiasis, picrosporum infections, genital warts, herpes simplex virus, even leprosy can worsen. Uh, and Also, nevi and warts can either enlarge during this period of this anabolic status, or you can have development of new nevi, and sometimes people get worried about melanoma. Of course, melanoma can occur in pregnancy, but is not so common, not rare, in fact, in our part of the world. Fortunately, due to the Th1 cytokine profile being limited, psoriasis improves. Acne can go both ways during pregnancy. Uh, some of the important conditions unfortunately, one type of psoriasis, that is generalized pustular psoriasis of pregnancy, can become a life-threatening condition. It is anyway a very serious form of pregnancy, and the clinical presentation is with erythematous patches studded with pustules, often in the flexures, and accompanied by systemic symptoms such as fever, neutropenia, and hypocalcemia, usually seen in the third trimester of pregnancy, but resolves after parturition. Uh, there can be adverse fetal outcome in the form of IUGR or fetal loss. Usually, generalized pustular psoriasis is treated with acitretin, a retinoid, which is a teratogenic drug and therefore is contraindicated in pregnancy. Also, you cannot use some of the cytotoxic drugs we use, such as methotrexate. However, cyclosporine is the drug of choice, and oral prednisolone is this is one of the instances where you can use oral prednisolone in psoriasis. Usually, this is contraindicated in pregnancy. Along with that, of course, we give supportive topical care as well as ultraviolet therapy also can be used. Acne in pregnancy can go both ways. In early pregnancy, it can worsen, but usually you can manage with topical applications. Here again, you cannot use topical retinoids, which are teratogenic, so we manage with topical benzoyl peroxide and topical antibiotics. Regarding SLE in pregnancy, uh, although it is thought to have an adverse outcome, some studies show that it's not as bad as thought earlier. If the female had been in remission prior to conception, at least for 3 months before, usually pregnancy can be well tolerated. And out of flares, cutaneous flares are the main manifestation of manifestation in SLE, and usually in the form of vasculitis, painful vasculitis. And regarding the fetal outcome, you may have about 1/3 of pregnancies may result in premature births or even fetal loss. There can be maternal adverse effects such as preeclampsia and thrombotic events. And in the event of antiphospholipid syndrome, they may come with thrombotic events. During pregnancy, hydroxychloroquine can be safely continued. If necessary, azathioprine and cyclosporine also can be given. Regarding neonatal lupus, this is due to passively acquired antibodies, especially anti-Rho antibodies. However, out of those who do have Rho antibodies, only about 2% of babies do develop neonatal lupus. This is characterized by annular scaly plaques. They may also have congenital heart block and thrombocytopenia. The good news, once again, is that this settles within 6 months spontaneously. Let's get on to the pregnancy-specific dermatoses. The most benign of these is the polymorphic eruption of pregnancy, also referred to as PUP, stands for pruritic urticarial papules and plaques of pregnancy. Very common, very benign. We love to see patients who have this because we can reassure them that this will go away after partus, and this has no adverse effects on either the mother or the fetus. They are recognized by the polymorphous nature of the lesions, meaning they are papules, plaques, targetoid lesions, polycyclic lesions, and characteristically they start on the abdomen in the striae, and characteristically there is periumbilical sparing as shown in this picture, can spread on the trunk but is not usually seen on the peripheries, on the extremities. Some of the risk factors for development of this is excessive stretching, so excessive maternal weight gain and multiple gestations. And this does not recur in subsequent pregnancies, and management is with topical corticosteroids and antihistamines. Getting on to a commoner eruption in pregnancy, the atopic eruption of pregnancy. There were many terms used for these conditions, but now it's all lumped into this category called atopic eruption of pregnancy, which has two types, the more eczematous type or the more papular type, which looks like papular urticaria. It can happen in people who are already having atopic eczema or who have not had, the majority who have not had atopy before. Appears earlier in pregnancy in the first trimester, unlike the polymorphic eruption, which occurs usually in the third trimester. Here the lesions are mostly on the peripheries. Has to be differentiated from common conditions like scabies and papular urticaria. Also recurs in subsequent pregnancies. The IgE level is usually high. Again, fetal and maternal prognosis are excellent. You can manage them with topical corticosteroids along the lines of usual management of eczema and antihistamines, and if necessary, phototherapy. Then we get on to pemphigoid gestationis, which is a more serious condition. It is an autoimmune bullous disease seen in pregnancy, where autoantibodies are directed at the dermoepidermal junction. Uh, Usually occurs in late pregnancy or in the immediate postpartum period, and can recur in subsequent pregnancies. Now, the main differential diagnosis would be the polymorphic eruption of pregnancy, but here you can see there is no periumbilical sparing. And in the pre-bullous stage, there can be confusion, but of course, once vesicles develop, you can suspect the condition. It can be confirmed by biopsy and immunofluorescence. And again, recurrences and flares are seen in subsequent pregnancies and even when you are on the oral contraceptive period. The distribution is similar to polymorphic eruption of pregnancy. The difference would be that there would be blister formation. And we diagnose using a simple biopsy and immunofluorescence. Regarding the baby, there is a fetal risk of prematurity and small for gestational age. The neonate may develop a transient eruption just like the mother, and you can manage this condition with both topical as well as systemic corticosteroids. Sometimes refractory disease can be treated with plasmapheresis. The most dangerous condition, pregnancy dermatosis in pregnancy, is intrahepatic cholestasis. It is a rare, genetically linked, hormone-dependent condition and presents with dramatic pruritus starting on the palms and soles. Uh, Elevation of serum bile acids will clinch the diagnosis. Actually, there are no rashes. There are no primary skin lesions. All changes are secondary to just itching. So when you go on scratching, you end up with papules and even nodules. Jaundice is seen only in about 10% of patients. And there is a very high risk to the fetus in the form of premature births in a large number of patients, uh, fetal distress, and in the mother also there can be postpartum hemorrhage due to vitamin K deficiency. Treatment is with ursodeoxycholic acid as well as topical applications. So this is an algorithm where the main four pregnancy dermatoses are uh, approached, where if there is no rash, it is intrahepatic cholestasis of pregnancy, whereas there are special rashes in the other three. Then getting on to some non-specific dermatoses of pregnancy, you can have the day-to-day pregnancy eruptions like pityriasis rosea. You need to be able to differentiate these from the specific pregnancy dermatoses. Then you can get urticaria. These are all managed with simple topical applications, and urticaria is managed with antihistamines. You can have your day-to-day viral exanthemata or drug reactions. Regarding certain infections, scabies is slightly commoner in pregnancy, and it's diagnosed in the usual way with the classical distribution of scabies. And permethrin can be safely used in pregnant mothers, although it's a category B drug. Regarding herpes zoster, there is a slightly higher risk of reactivation of zoster, and here again, acyclovir can be safely used in pregnancy. Varicella infection can be a little serious for the mother. There may be complications such as pneumonia, hepatitis encephalitis may also occur, and acyclovir has to be instituted immediately. And neonatal varicella occurs, especially if the mother gets the infection 1 week prior to partus or 1 week postpartum. There are different routes of infection, including transplacental spread. Uh, and you get the usual blistering eruption just like in normal varicella. There is a mortality rate without treatment of 30% in these infants. There is a place for passive immunization with varicella zoster immunoglobulin in the babies where the mother has developed varicella, and these babies have to be observed for the development of the condition. Congenital varicella syndrome is different, where you have the baby has got it during during weeks 13 and 20. There can be skin scars like a herpes zoster scar, or there can be other adverse effects, neurological effects as well. Herpes simplex infection is usually not a big problem. It happens during childbirth, can be treated in the usual manner with acyclovir. Genital warts can exacerbate during pregnancy. Uh, Treatment is usually with cryotherapy or liquid nitrogen treatment or acid ablation. Uh, Immunomodulatory agents like imiquimod are contraindicated in pregnancy. Candida vulvovaginitis can be treated with topical antifungals in the usual manner. However, oral antifungals are contraindicated. A few words about corticosteroid usage during pregnancy. Topical steroids are usually safe. We prefer mild to moderate corticosteroids and prefer to avoid clobetasol, which is a strong corticosteroid, especially to large areas of the body because there can be absorption and lead to systemic steroid effects. When you do need to use steroids, prednisolone is a drug of choice. It's usually largely inactivated in the placenta. If used in the first trimester, there's a slightly higher risk of cleft lip and palate formation, and therefore we prefer low doses for shorter duration. Regarding antihistamines, first generation antihistamines are considered safe. During the second and third trimester, you can use clotridine and cetirizine as well. So, the take-home messages I would like to give are during pregnancy, there are these profound immunological, metabolic, endocrine, and vascular changes. And these makes the pregnant women susceptible to many changes of the skin and appendages, sometimes physiological, sometimes pathological. One needs to be able to recognize the physiological changes and reassure these patients, and also correctly diagnose and start appropriate treatment where necessary when there are more significant dermatoses. Pruritus is the commonest complaint during pregnancy and could be related to a pre-existing dermatosis which could flare up, or this could signify the onset of a specific pregnancy dermatosis. Thank you. I'd like to acknowledge my Registrar Dr. Nitya Gunawardhan and Senior Registrar Dr. Rajivi Abhinayaka for their help with preparing this presentation. Thank you.
Thank you, Madam, for that wonderful and simplified presentation on managing skin problems in pregnancy. We'd like to invite our listeners to post in questions through the chat box. Madam, you mentioned about antihistamines in pregnancy. You mentioned about clofendramine, the loratadine, cetirizine. What about newer antihistamines that are used, like fexofenadine, and even you see that many people, including non-dermatologists, use rupatadine. Yes, what are your thoughts on that?
Actually, most of the studies have been done for loratadine and cetirizine. However, there are no real studies to show that fexofenadine is contraindicated. But because we have backup studies for these, we prefer to use these two antihistamines. Rupatadine is quite new. I don't think there is enough data at the moment for usage in pregnancy yet.
And with regards to psoriasis, is there any change in the paradigm during pregnancy? If a patient has pre-existing psoriasis, is there any change of appearance, and is there any change in the management, because most of the drugs are toxic, teratogenic in pregnancy?
Absolutely. So actually, as I showed earlier, because of the change of profile, most people's psoriasis actually improves during pregnancy. So we mostly manage with topicals. It is only that serious type, the generalized pustular psoriasis, which tends to flare up, which can be even a life-threatening condition. So we manage generally with topical applications in the usual way. We do not use retinoids, either topical or oral retinoids, of course, because of the teratogenic risk. If necessary, even phototherapy, narrowband UVB can be used safely in pregnancy. Of course, needless to say, cytotoxic drugs such as methotrexate are completely contraindicated during pregnancy.
Another question is with regards to hypersensitivity reactions in pregnancy. Can you give us some insight as to any new developments or any changes in the management of hypersensitivity, especially skin hypersensitivities to simple agents? Is there any new thoughts on that?
When you say hypersensitivity, are you referring to urticaria?
Yes, urticaria.
Yeah, so urticaria, the cornerstone of management of urticaria is with antihistamines. As I mentioned, we prefer always to use the first generation antihistamines like chlorpheniramine. However, if necessary, you can updose with second generation antihistamines as well. Usually, there is no place for topical steroids in urticaria other than just local urticaria due to some topical agent. Uh, Steroids can be used if absolutely necessary, but we limit, of course, courses of steroids to short courses. Anyway, in chronic urticaria, as a principle, we prefer to avoid oral steroids because patients become dependent on steroids. So we follow and treat along the same lines even during pregnancy.
Another condition that comes up in pregnancy is people tend to say that they crack their skin, especially the soles. Is there sort of like tips that you would recommend in management in pregnant as well as non-pregnant females?
Yes, so mainly cracking is related to dryness of the skin. So use of soap substitutes as well as judicious use of emollients is what is recommended. There are certain emollients with special additives like 10%, 15% urea, which we would prefer to avoid during pregnancy. In non-pregnant people, of course, you can use such topical applications. And you have to use them frequently, and sometimes you have to use, especially for the soles, you have to use them under occlusion as well.
One final question. We have a question from an enthusiastic registrar. What are the topical agents that can be used in pustular psoriasis? As steroids are generally not used in pustular psoriasis.
Mostly, pustular psoriasis has to be treated systemically, so topical applications are mainly emollients. That is what we prefer to use. I mean, to localized areas, sometimes we do use if it is accompanied by a regular psoriatic plaque, a scaly plaque, we can use topical steroids. That's not contraindicated, but mainly it will be emollients.
Thank you, madam, for that excellent presentation and for the lively session of question and answers. We move on to the next presentation, and this presentation is on a disease that we have forgotten or we have sort of taken for granted during this year because of the pandemic. When we now move on to dengue hemorrhagic fever, pitfalls of dengue hemorrhagic fever in pregnancy, the margin for deviation away from guidelines. And we indeed have elite presenter, Dr. Priyankara Jayawardena, who is the consultant physician at the Disoisa Maternity Hospital. Over to you, Dr. Jayawardena.
Good morning. First of all, let me thank for the physicians for inviting me today. And the given topic pitfalls of the hemorrhagic fever in pregnancy and symptoms of where we deviate from the guidelines. My talk is based on basically our own national guidelines and why dengue is important. When we talk about causes of maternal death in year 2017, dengue hemorrhagic fever was the leading cause of maternal death. followed by heart diseases and respiratory diseases. So you appreciate the medical causes are the leading causes of maternal deaths now, and the traditional causes like sepsis and septic abortions and obstetric hemorrhages, the incidence are less. When we talk about dengue hemorrhagic fever, we know the pregnancy is the number one risk factor for dengue hemorrhagic fever. In addition to that, if mother get dengue during the pregnancy and after the delivery, you know that mother produce antibodies. These antibodies go to the newborn, and the newborn baby gets dengue. Uh, in first 6 months of life, they behave as if it is a secondary dengue. Another thing, after the delivery, if mother, a pregnant mother, after the delivery, if she gets dengue, most of the time they are on regular NSAIDs. You know, NSAIDs is a known risk factor for dengue. And when we talk about the dengue during pregnancy, important to know the clinical manifestation, but it will be the same as non-pregnant one, but the complications are more. We have to have an idea about the normal physiological changes of pregnancy when we manage dengue mother, and what happened uh, to the pregnancy outcome due to the dengue, and how the dengue infection affects the fetus and neonate. But the management in pregnant women is not different to the management of non-pregnant adult. When we talk about the physiological changes of pregnancy, we know certain physiological changes happen in the cardiovascular system, like in pregnancy, the pulse rate goes up. So in pregnancy, the pulse rate could be 100 even, so tachycardia. In pregnant mother, we have to think twice whether it's due to the hemorrhagic fever, whether it's due to a normal physiological change. In pregnancy, as a normal physiological change, they get peripheral vasodilatation. So systemic vascular resistance reduce, leading to reduced diastolic blood pressure. So because of the low diastolic blood pressure, the pulse volume, pulse pressure get widened. And we know in dengue hemorrhagic fever, we talk about low volume pulse pressure. That is, if it is less than 20, we think about dengue shock syndrome. But when it happens in the pregnancy, it could be a higher pulse volume like 25. And the blood pressure is a very important parameter when we manage dengue patient. In pregnancy, there's an impact of maternal posture on blood pressure, what we call supine hypotensive syndrome in pregnancy. When the mother in supine position with a gravid uterus, venous return to the heart will be reduced by at least 30% because of the compression of the IVC by the gravid uterus. So we should know that, especially when the blood pressure is low in the supine position, we have to change the posture and check the blood pressure before taking a drastic decision. In normal pregnancy, pulmonary vascular resistance reduce and increased pulmonary blood flow with increased capillary permeability, which is pathological important in dengue hemorrhagic fever. In pregnancy, uh, the plasma volume expanded as a normal physiological change, and it will expand at least by 50% at the time of delivery. And the blood volume also gradually increase uh, at least by 20%. And we know that during the labor, due to uterine contraction, some amount of blood in the uterus will come back to the maternal circulation. And after the delivery, because of the complete uterine retraction, more blood will come back to the maternal circulation. If you get a scenario like that, a pregnant mother, term delivery platelet count is 10,000, and the patient is delivering, and you are going to give blood, and then you have to calculate that the amount of blood in the uterus will come back to maternal circulation. You have to have idea while giving the blood to the mother. And a pregnancy, uh, when though they are when they are having dengue, they may not show the features of typical hypovolemia because they have certain physiological adaptations in pregnancy, so they may not show the features of hypovolemia like non-pregnant one. So we should know about this, and we should think blood transfusion in dengue hemorrhagic fever, even with normal blood tests. And in pregnancy, uh, when there's evidence of leaking and bleeding, when the uteroplacental blood flow is affected, the mother may not show any signs or symptoms, but fetus will show the evidence of fetal distress. So fetal distress could be the manifestation of maternal hemodynamical decompensation in pregnancy, especially in the leaking phase. So as I told you, in pregnancy, maturity, the plasma volume get increased. Likewise, the red cell mass also get increased. Red cell mass could be increased up to 20%, while the plasma volume could increase by 50%. So there will be some kind of physiological anemia in pregnancy. So think about the scenario: a woman who is not pregnant and her hemoglobin is 15, PCV is 40, and for her to have 20% rise in the leaking phase, it should be 48. So we are used to manage non-pregnant ones, so we expect high hematocrit value like 45, 48, maybe 50 when we think about leaking. But the same woman, when we get pregnant, the hemoglobin will come down to 10 and the hematocrit will be 30. And for her, 20% increase will be 36. So you should appreciate the, the low value like 36 of PCV could be an indication of fluid leakage. In pregnancy, the white cell count will go up. So there will be leukocytosis. So the traditional leukopenia in dengue may not see in pregnancy, so it could be a pitfall. The platelet count be decreased as a part of the physiological change in the pregnancy. So it is called gestational thrombocytopenia. But usually that count is more than 100,000. But there are other pregnancy-related conditions like preeclampsia and HELLP syndrome. These conditions also, the platelet count will be low. So you should understand and you should be able to differentiate the pregnancy-related conditions and dengue fever when you have thrombocytopenia. But by the time if they go to delivery, the platelet count, especially vaginal delivery, more than 50,000 usually is adequate. We know the pregnancy is a prothrombotic state because there's a accumulation of coagulation factors and the fibrinolysis is reduced and increased platelet activity. So thromboembolic complications are more in pregnancy. But when dengue occurs, the platelet count will reduce and there is a risk of bleeding and there's a possibility of consumptive coagulopathy. So if you get a kind of complicated dengue patient, pregnant one, it's a good idea to do a thromboelastometric study and get opinion from the hematologist while you are correcting the clotting factors. And serum albumin is low in pregnancy and the cholesterol is high in pregnancy, though, so those values are not much used in critical phase. We know in pregnancy, the functional residual capacities decrease because the gravid uterus occupied the part of the lungs and the lungs will get compressed up. Because of that, the respiratory rate will be high in normal pregnancy. And because of that, there is a compensated respiratory alkalosis with high PO2 and low PCO2, which is normal in the pregnancy. In pregnancy, the oxygen consumption is elevated. And if you get a bit of acidosis, you have to correct it faster than an unpregnant one. So what happened to the renal kidney in pregnancy? In normal pregnancy, renal blood flow increased at least by 80%, and because of that, the GFR is increased. And in pregnancy, they have a true polyuria. They may pass at least 3 liters of urine per day. In dengue shock syndrome, in pregnancy, it's part of the adaptation and physiological changes. The intense thirst may not appear despite intravascular volume depletion. So you have to be very careful. And the urine output may be normal because of the high renal plasma flow. So again, urine output may not be a good marker in the management of the dengue in pregnancy. So it's an area we have to be careful. When we go through the spectrum of infection in dengue, we know most of them are asymptomatic or maybe having simple dengue fever. But if dengue happen in pregnancy, there's a higher chance of getting or go to dengue hemorrhagic fever. or they could end up with features of or complications like extended dengue syndrome. We know how to differentiate the dengue fever and dengue hemorrhagic fever. And dengue fever basically no plasma leakage, but you can get hemorrhagic manifestation in simple dengue fever like gum bleeding and nasal bleeding, maybe a bit of hematuria. In pregnancy, bleeding PV could uh, happen in simple dengue fever. It's not essentially dengue hemorrhagic fever. Dengue hemorrhagic fever, we know that why we call dengue hemorrhagic fever, there should be evidence of fluid leakage or there should be evidence of internal bleeding. When we talk about the fluid leakage, traditionally we go by high PCV and high HP, which will not happen in pregnancy. So you have to go by the hematocrit. So you should get the baseline hematocrit and to see whether there's a 20% increase. So the hematocrit may be as low as 36, and she may be in the leaking phase. And there are the albumin and cholesterol level. Albumin is low and the cholesterol is high, so no point doing those things in a pregnant lady. And when they have mild pleural effusion and ascites with pregnancy, you have to be little careful when you do the scans. In normal, in the natural course of dengue fever, we know there's febrile phase and critical phase and the convalescent phase. Traditionally, we are not much worried about the febrile phase and we are concentrated about the leaking phase. But when it comes to the pregnancy, in the febrile phase, high fever could be the killer to the fetus. So you have to control the temperature with regular paracetamol and tepid spongin, etc. And usually we don't talk about the full blood count in day one in non-pregnant dengue patients, but in pregnancy, it's a good idea to do a full blood count in day one to know the baseline PCV. And when we get diagnosed as dengue hemorrhagic fever or dengue shock syndrome, there are parameters which are known to us. And the hemoconcentration is the most important thing in pregnancy. When you manage the fluid in dengue, and we know in dengue hemorrhagic fever, in the leaking phase, there's a fluid quota, and there is some kind of a fluid restriction. So fluid management is the cornerstone of the management of dengue hemorrhagic fever. And traditionally, we advise the patient to drink water rather than giving IV fluid. And we should understand in pregnancy, they may not be able to drink adequate amount of fluid, especially in the first trimester. So it's a good practice to start a normal saline drip. In pregnancy, how do you calculate the body weight? You go through the notes and get the pre-pregnancy body weight. And pregnancy urine output may depend on the posture, especially if they are on the supine position. The urine output may not be good, so you have to change the posture. And when the patient is critically ill, and try to get a good urine output and see whether the urine output is really low. And when we consider colloids or dextran, when we think about the leaking phase and patient is having low urine output, and when traditional vital signs like tachycardia and blood pressure, I told you these signs may not appear until late stages in pregnancy. So you may not get your traditional, the usual high PCV in leaking phase in pregnancy. So PCV may not be very high in spite of leaking phase. If you are having a kind of unstable vital sign, get a scan and consider dextran or colloid transfusion. And again, plasma has no place in leaking phase. And sometimes we get patient transferred from some other place, hospital, or maybe with inadequate records. And sometimes we are wondering whether the patient is given lots of fluid and whether the patient has got fluid overload, especially in the critical phase. And the traditional way that we look for the fluid overload is difficult in pregnancy because anyway some pregnant women are having generalized body swelling. So it may be normal in pregnancy. So you can't cut down the fluid. And usually when they're having respiratory distress and difficulty in breathing, rapid breathing, we think there's a fluid overload. But in pregnancy, these things could be normal because of the reduced functional residual capacity and less oxygen reserve. So we have to be very careful. When we give the blood, we expect significant amount of blood loss with the PCV. And in pregnancy, again, because of the hemodilution, anyway, the hemoglobin could be low and the PCV could be low. And after the delivery, the postpartum period, you may get a patient, the HB and PCV may be low because after the delivery, anyway, they bleed some amount of blood. So you have to be careful. And you have to have a low threshold to give blood. Sometimes you may get a patient dengue or after during the pregnancy or after the delivery. On admission, HB may be 9 or 10, and then this is not in the leaking phase. It may be a good practice to give blood transfusion before they go to leaking phase, and these things are not in our own guidelines. And this is then otherwise it may be difficult to save the patient when the patient is hemodynamically unstable. And we all know when the leaking and internal bleeding happen simultaneous, especially in pregnancy, at CT, the PCV could be normal. And why bleeding happen in dengue hemorrhagic patients? It could be due to the increased capillary fragility. It could be due to the thrombocytopenia. It could be due to the coagulopathy. It could be due to the liver failure. So those are the main causes for bleeding in dengue hemorrhagic patients. But in pregnancy, all these factors favors because of the physiological changes in the pregnancy. And in pregnancy, it's unique. There are certain situations you get in pregnancy, suddenly you get a patient with low platelet count and elevated liver enzyme. So then you may wonder why, whether it's a dengue fever or whether it's a HELLP syndrome. As the management is totally different. The HELLP syndrome management is you terminate the pregnancy and deliver as soon as possible. Whereas in dengue hemorrhagic fever, you try to postpone the delivery. In HELLP syndrome, you get evidence of in HELLP syndrome, you get low HB, elevated liver enzymes, and low platelet, plus evidence of preeclampsia like high blood pressure and urine albumin positive, this kind of other evidence which you should look for. And it's a good idea to get a blood picture and get your opinion. And when you do the liver enzymes, both SGPT, SGOT, both will be high with high LDH level. In that case, you have to discuss with the VOG for early delivery. In dengue hemorrhagic fever, there is a history of fever, and if you do a scan, there may be evidence of fluid leakage. And if you compare the SGPT, SGOT value, SGOT may be higher than the SGPT. So then you have to be careful and try to postpone the delivery. Usually in dengue, there's no place for dengue hemorrhagic fever in non-pregnant one, almost no place. But pregnancy is a very exceptional case if the patient is going for vaginal delivery in spite of thrombocytopenia. With thrombocytopenia, or section is essential, maybe with a short shoulder presentation, or if the pregnant mother is continuously bleeding after the delivery, after giving adequate amount of blood, then you have to consider giving platelets. Dengue shock syndrome, the features, but in pregnancy, they are more prone to go for shock syndrome. And other complications, like extended dengue syndromes, those complications like encephalitis, hepatitis, and myocarditis are common in pregnancy than non-pregnant women. Why people die in dengue? Because of the shock, or maybe due to the fluid overload. Pregnancy, most of the time, diagnosis is delayed due respect to the VOGs. The patient will go to the VOG first, and they should think about dengue and come back to the physician. And it could be late presentation, especially after delivery. If they go home, if they get pregnant dengue at home, then they don't come back to the hospital. The blood transfusion and other management could be late because of the late presentation. When you do lab, the blood test, we know that the pregnancy HB and HCT could be low. It may be due to the physiological changes, so we have to be very careful. In pregnancy, you get leukocytosis. So one might think this is not a viral infection. The high white cell count be due to the pregnancy. Platelet count could be low due to the pregnancy, though we have to be careful. It's a good practice to do a CRP or procalcitonin to see whether there's evidence of bacterial infection. So if pregnant mother get dengue, so she could end up with abortion, liver failure, bleeding, or even death could happen. And dengue at the time of delivery is very dangerous. This could happen. These are not unusual hypothetical scenarios. There are lots of instances that the patient, pregnant mother, dengue, they come in that a term, maybe going to deliver. We can't stop the delivery, so we manage with the VOG, and you have to. It's a kind of a combined management. Dengue at the time of delivery, it could be hospital acquired. If the patient is in the hospital for a few days, so she must have got it from the hospital, might have got it from the hospital. Another thing, if they get if the pregnant mother after the delivery, if she get fever, the obstetrician might think it's due to infected episiotomy or urinary tract infection, because during the pregnancy and after the delivery, few pusses in the urine is common. So you have to be careful, and always we should think about dengue. And after the delivery, if the mother gets dengue, and sometimes they are on regular NSAID analgesics, so it could adversely affect the dengue outcome. And postpartum period, HB and PCV is low. And other thing, when they go home, and if they get dengue at home, because of the baby, their mothers are reluctant to come to the hospital. If what happened to the baby if mother get pregnant, get dengue during the pregnancy, and there is a possibility of fetal death or premature birth. And if the mother get the dengue before delivery, and then if the baby after the delivery within 4 or 5 days could get dengue because of the vertical transmission. And if mother get dengue during the pregnancy, she produce antibodies during the pregnancy. These antibodies could cross the placenta and go to the fetus. And if it could last for 6 months in the newborn circulation, if newborn gets dengue for 6 months, because of the presence of maternal antibody, they behave as if it is a secondary infection. So dengue recovery, you know that the features of recovery we all are very familiar. But before you discharge a dengue mother from the hospital, you should know that when she go home, there are lots of social scenario. If she going with the baby, lots of people come to see the baby, and there's a social event. So mother has no choice; she has to show the baby to the people who visit home. So you have to be then mother is not given the priority. Priority is given to the baby. So we don't discharge the patient until she fully recovered. So take home messages are. Dengue hemorrhagic fever and medical problems are the leading cause of maternal mortality in Sri Lanka. So we physicians have a big role now. And pregnancy is a high risk condition for dengue as it affects the mother and baby. And we have to have an idea about normal physiological changes during the pregnancy. It's very important to know. And tachycardia and wide pulse pressure can mislead the dengue hemorrhagic fever, which is normal, could be normal in pregnancy. Low HB and low PCV during pregnancy and post delivery could be considered in the management of dengue patient, especially when we consider blood transfusion and giving dextra and infusion. Fetal distress could be the manifestation of maternal hemodynamic decompensation. It's important to control the fever from day one, because fever could be the killer to the fetus, and useful to have a full blood count on day one to have an idea about the baseline HB and PCV. Fluid calculation according to the pre-pregnancy body weight. And leukocytosis and thrombocythemia may be normal in pregnancy. Low albumin and high cholesterol in pregnancy could be misleading, especially if you do it in the leaking phase. Tachypnea and respiratory alkalosis may be normal in pregnancy. Fluid overload may be difficult to assess during the pregnancy because anyway they are having evidence element of fluid overload. Blood pressure may change according to posture, so you have to be careful. Urine output can change according to posture and may not be the good indicator to diagnose dengue shock syndrome because usually they are having a good urine output. Dextran should be considered without high PCV, so you have to have a bit of a liberal idea, and blood transfusion should be considered even with mild bleeding. And we should not miss preeclampsia HELP syndrome when platelet is low and the left is high. Platelet transfusion should be considered when there's a dengue positive mother with thrombocytopenia and the delivery is inevitable. Dengue during pregnancy and postpartum period should be late diagnosis because the patient will go to the VOG and come to us. And it could be a late presentation because they don't like to come to the hospital. Newborn baby can get dengue from day 1 to day 5 from the maternal infection because of the vertical transmission. If the infant get dengue in the first 6 months, they could behave as a second episode of dengue, as a secondary dengue. And before discharge, we should consider the social situation at home for mother's safety, and we should discharge once the mother is completely safe. Thank you very much.
Thank you, sir, for that presentation. We invite our viewers to pose in questions again. There are several questions. If there is fetal distress, do you encourage delivery in third trimester in a lady with dengue?
No, when you get a patient with dengue, mother, then always you should have a discussion with the family and VOG, and mother is given the priority, and mother's life is the priority. So we observe those things, but the priority is given to mother, and we are not going to encourage the delivery section or normal delivery, considering the fetal distress. Mother's life and the maternal mother is the priority. That we have to discuss with the family and the VOG. We have to come to agreement about that.
When one gives a flush of normal saline, dextra and boluses of blood, are the expected changes the same, or are there any different cutoffs in pregnancy?
No, we don't get the expected changes like the rising HB and rising the PCV. So we have to go according to the. Then you should think about the time which grade she's in the. If she's the early pregnancy, yes, you may get the expected cutoff values. But in the late pregnancy, then you don't get those things. Then you have to go with the pulse, blood pressure, urine output, and maybe doing an ultrasound scan, assess the fluid status. Then you have to take it as whole.
Are there any changes in management of dengue-related complications such as dengue myocarditis and dengue hepatitis?
No, there's no special management. We have to go through the same way, but not like non-pregnant ones. If some pregnant ones get dengue, especially towards the term, always you should look for those complications, doing an echo and frequent liver functions. Sometimes they may recover from the dengue, then they go to the HELP-like syndrome. So you should keep monitoring them. So management will be the same, but you should look for those things, doing echo and liver, checking the liver enzymes more frequently.
Okay. In the interest of time, we move ahead, and we thank Dr. Priyanka Rajawardena for being with us for this simplified approach in managing dengue hemorrhagic fever. Our next presenter will be Dr. Lalindra Gunaratne. He's a consultant hematologist and a senior lecturer attached to the Faculty of Medicine, University of Colombo. And his presentation is on a very grave, very serious problem that comes across in pregnancy, how we should manage thrombotic and thromboembolic disorders in pregnancy. His talk will be focused on how to suspect it and how to intervene. Over to you, Dr. Gunaratne.
Good morning to all of you. So I'm supposed to talk about thrombotic and thromboembolic disorders in pregnancy. And to start off with, let me just show you this diagram because we know that thrombosis occurs in pregnancy mainly in the venous system, and you can also get arterial thrombosis. And when we talk about the venous system, we are particularly interested in the deep veins of the body. And when we talk about the deep veins, we need to appreciate the fact that in the lower limbs, we consider the popliteal vein as the point at which we distinguish between proximal and distal thrombosis. So if there is a patient who has a popliteal vein thrombosis, we would consider that patient to have a proximal thrombosis, and something more distal to that, we would say is distal thrombosis. Also, a word about this venous system. There is the superficial femoral vein, and although it is referred to as the superficial femoral vein, if there is a thrombus in the superficial femoral vein, we would treat it as a deep vein. And this is something which people can get confused with because of the nomenclature. But remember that it has the same problems. And one of the main problems in the deep veins is that it can embolize. And that's why we make a distinction between the proximal and distal veins. We can also have thrombosis occurring in the microvasculature, and then we would refer to it as microangiopathic thrombosis or thrombotic microangiopathy. Having considered these three things, let's look at VTE or venous thromboembolism in pregnancy. We know that pregnancy is a prothrombotic state, and the reasons for that are many, including the fact that there is a large amount of estrogen, and VTE is an important cause of maternal morbidity and morbidity in the Western world. We have to say Western world because we don't have much data on this in Sri Lanka. Just to drive home a point, in the UK between 2014 and 16, the top cause of direct maternal death was VTE, or 1.39 per 100,000 pregnancies. The relative risk of thrombosis is about 5 times higher in a pregnant woman than non-pregnant women of similar age, and this could even increase to tenfold in pregnancy. During the postpartum period, especially after cesarean sections, the daily risk of VTE is nearly 30-fold compared to non-pregnant women. However, the absolute risk of developing VTE remains comparatively low to the degree of hyper or prothrombotic state. Therefore, the estimated incidence of pregnancy-associated VTE can vary between about 1 in 500 to 1 in 1,500 pregnancies. Again, it is important for us to understand this time frame and the occurrence of thrombosis. You can see that although there is a slight increase in thrombosis when it comes to throughout pregnancy, when it comes to the third trimester, it increases steadily, and around about the time of delivery and about a week after delivery, there is a very, very high risk of thrombosis, which persists or gradually declines over the next 6 weeks or so. So when we think about the most prothrombotic period in a woman's confinement, it would be somewhere starting from the third trimester until about 6 weeks after delivery. And you will appreciate the fact that all the guidelines suggest anticoagulation during this period. So sometimes, according to the guidelines, they will say in this person with this thrombotic risk, you need to give thromboprophylaxis in the 6 weeks postpartum. Uh, what are the risk factors for VTE? And this study has looked at about 21,000 women, and you can see that overweight or obesity is one of the uh, leading factors which go with VTE risk. Also, uh, I think it's not very clear in this, but uh, the recurrence of VTE is also a high risk factor, and the type of delivery, cesarean section, and let's say emergency cesarean section, it is slightly more than that of a normal cesarean section. So in this, if you see, about 78% had at least one VTE risk factor, and more than 40% had multiple risk factors. So this is important that so that we need to continuously assess the thrombotic risk in this group of patients. People talk about thrombophilia screenings, and I think it's important to note that in this group of patients, the risk of having a hereditary thrombophilia is not very significant. Even in the West, you can see that the causes of hereditary thrombophilia, like factor V laden and prothrombin gene mutations, account for about 5 to maybe 8% of uh, VTE during pregnancy. Uh, Severe antithrombin 3 deficiency is also such a cause. So I don't think it is very important for us to consider, screening for these thrombophilia tests during or when someone is approaching pregnancy, unless they have a strong family history. This is some more recent data, and why I put this up is for you to understand why the RCOG has put out various guidelines saying or stressing the importance of risk stratifying these patients at different points of time. So, at booking, during the third trimester, then at delivery, and post delivery. You can see here that if someone has a high BMI, plus there is antepartum immobilization, then the adjusted odds ratio is about 60% of developing a VTE. So if you have a woman whose BMI is high and for some reason has to be hospitalized and is in bed for 2 or 3 days, you know that that patient is at a significantly high risk of developing a VTE. Then prior VTE also is important, especially we say if it is an estrogen induced VTE. So if a woman has developed a VTE while on the oral contraceptive pill or else during pregnancy, then she is at a very high risk of developing VTE in the current pregnancy as well. The other thing is infections. This is mainly in the postpartum period or the peripartum period. Infections also can give rise to the very prothrombotic state. So it is based on evidence like this that the RCOG has come up with this risk assessment for VTE, which all of you I know are very familiar with. So if you look at this patient who is a 21-year-old woman, 23 weeks into her first pregnancy, presents with swelling of both lower limbs, the left being more than the right, and you can see that the right lower limb just had swelling around the ankles, but the left had pain and swelling below the knee. She's traveled quite a long way about 3 days before, and while visiting, she had gone to see her GP and got some antibiotics and paracetamol for the same. Uh, we use pretest probability scores like Wells score to assess the probability of a woman having VTE. However, in pregnancy, we know that this sort of probability score is not very useful because we know that pregnancy per se can have these women can have some swelling of the legs just in pregnancy per se. The D dimer is also a test that is usually used, but it is not useful in pregnancy because pregnancy per se can cause high D dimer levels. So what is important is then the clinical suspicion, and once you suspect it clinically, using compression duplex ultrasound scan to confirm the same. So this is just a line diagram or an algorithm for us to uh, diagnose patients with VT in pregnancy. If there is a delay, once a clinical suspicion is made, if there is a delay in performing this ultrasound duplex scan, sometimes it's difficult to get over the weekend, it is always better to start them on low molecular weight heparin if there is no contraindication. And then once the scan is done, if it is positive, you just continue it, and if it is negative, you can discontinue it. Once the scan is done and it's negative and your clinical suspicion is low, then you can omit anticoagulation. However, even if the scan is negative and you have a high clinical suspicion of DVT, it is might be a good idea for you to continue the anticoagulation until you can get a repeat scan. Although there are different studies showing different data, we could sort of assume that about one there's a chance of about 1.5% that the DVT can be missed by the first scan and be picked up in the second scan. So, if you have a high degree of clinical suspicion of a DVT, it is always better to repeat a scan round about the third or the seventh day after suspicion. So this woman had a left iliofemoral DVT, and she was given started on low molecular weight heparin, which nowadays is preferred to unfractionated heparin. There is some debate whether a single daily dose of enoxaparin, 1.5 milligrams per kg subcutaneously, or a split dose of enoxaparin, 1 milligram per kg BD, is better. However, there is no strong recommendation. Uh, Either of these methods could be utilized for your patient. However, monitoring of anti-10A levels is not routinely recommended unless the woman is at the extreme of has an extreme of weight, or there is renal impairment, or the patient develops a recurrent VTE while on a therapeutic dose of enoxaparin. If VT occurs at term, then there is consideration of using unfractionated intravenous heparin over low molecular weight heparin, because it can be stopped quickly or manipulated in the event that the patient goes into labor. Again, if the patient in the peripartum period has renal impairment, it will be worth considering unfractionated heparin over low molecular weight heparin. These are some of the other low molecular weight heparins which are available. However, I think enoxaparin is one of the common drugs that we use in Sri Lanka. What about the duration of anticoagulation in a woman who has developed a venous thromboembolism? The recommendation is that there should be at least 3 months of treatment with low molecular weight heparin, and uh, if it occurs during pregnancy, we should make sure that this should continue for at least 6 weeks in the postnatal period as well. I'm going to pose a question now to you, and maybe give Shehan some work to see whether you can send some chats. You can see that on chat, isn't it?
Yes.
I'd like to see what you would respond to this. In an acute, uncomplicated DVT of a lower limb, if say the woman presents to you with a proximal DVT, uh, which is uncomplicated, that is, there's no pulmonary embolism involved, how long would you tell that woman to rest in bed? That is the question. So, what is the period of bed rest you would recommend in this woman? Sorry. So, until you send in your answers to Shahan, I'll continue with the lecture, and we'll see what your responses are. Right. So we get on to the second case, which is a 26-year-old woman who had a sudden onset shortness of breath and chest pain. In the 10th week of her first pregnancy, she was tachycardic, but her blood pressure was about 100 millimeters mercury. The D dimers were high. Her echo showed a right ventricular dilatation with a mild TR. She was started on enoxaparin 60 milligrams subcutaneously, and her duplex scan of the lower limbs showed bilateral lower limb DVTs. And what was worrying is that the distal end of the thrombus appeared to be unattached and was floating. So the question was, would you insert an IVC filter in this woman, because the uh, uh, the distal end of the thrombus was actually in the lower end of the IVC? The answer to that is given multiply in this slide, and you can see the Americans, the Canadians, the British, the Australians, New Zealanders, and whoever. The recommendation is that you do not use IVC filters even if they are temporary, if there is no contraindication to give anticoagulation. So it is strongly advised that you do not put an IVC filter even temporarily if the patient can be given full dose anticoagulation, because we must remember that an IVC filter is also a foreign object, and this also can increase the risk of thrombosis. Shahan, do you have any?
Yeah, for the previous question, uh, there are about 12 people who have said that no bed rest is not required, and only one person had said bed rest for 6 weeks postpartum.
Right. I think the answer has been given by the 12 people who have answered, saying that there's no bed rest. So this is also something very important, because recently we had a patient transferred from a distant place where the patient had been asked to rest in bed for quite a long period of time. So there is no evidence to say that resting post acute DVT is recommended. Actually, you should ask the patient, once the anticoagulation has been started, to mobilize as soon as possible, because this has been shown to actually decrease the risk of venous thrombosis. So the fear of having a pulmonary embolism occur is minimal, and should not these patients should not be encouraged to stay in bed. Uh, Another question is that I'd like to address at this point is the use of graduated compression stockings post lower limb VTE. Again, uh, the what the graduated stockings, what they do is to prevent post thrombotic syndrome, and therefore it is recommended mainly for patients who have a lot of or large swelling of the lower limbs, and this is in order to avoid post thrombotic syndrome. And there is no use in putting the stocking in the leg which is not affected, because we sort of tell the person to walk around. Again, we had a patient recently in whom the stocking had been put onto the leg which was not swollen, and the leg which was swollen was not attended to by with a stocking, because of the thought that it might cause problems. So again, if stockings are being used, they should be used only on the affected leg, the limb, and that also is to reduce post thrombotic syndrome, and also maybe give some comfort to a woman who's got very, very edematous feet. Uh, okay, so for pregnant women with acute pulmonary embolism and life-threatening hemodynamic instability, uh, the ASH guideline panel suggests administering systemic thrombolytic therapy in addition to anticoagulant therapy. So even in pregnancy, if a woman develops a pulmonary embolism and you find that her systolic blood pressure is less than 90, then there is a risk, there is a need either to give systemic uh, thrombolysis, or maybe even do a embolectomy. So, diagnosis of PE in pregnancy, the clinical suspicion of acute PE, once it has been sort of clinically suspected, you need to do a chest X-ray and ECG, and also look for features of DVT, which is more easily demonstrable than demonstrating a PE. And if there is, or if there are features of DVT on an ultrasound scan, then you need to manage this patient as a PE. If there is no evidence, then you have to go and perform either a CTPA or a VQ scan. And of course, if it is positive, then manage as a PE. If it is negative with a low clinical suspicion, omit anticoagulation. Uh, and if the clinical suspicion remains, we need to think of an alternative diagnosis, or maybe even repeat the test. So the management of PE in pregnancy: investigate, and if hemodynamically stable, start on low molecular weight heparin. If hemodynamically unstable, unfractionated heparin with systemic thrombolysis and an embolectomy. About unfractionated heparin, if we need to give it, remember that it has to be started with the loading dose of 80 units per kg intravenously, and thereafter 18 units per kg per hour. It is mandatory to monitor the APTT level every 4 to 6 hours after the loading dose, and 6 hours after any dose change, and then at least daily when in the therapeutic range. And the therapeutic target should be 1.5 to 2.5 times the average APTT of the laboratory. But what I would suggest is that before we start on any sort of anticoagulation, that you would do a baseline prothrombin time and an APTT, and you could use 1.5 times, 2.5 times that APTT. So if the woman's APTT, for example, is 30, then you would aim at keeping the unfractionated heparin at 45 to about 60, and this way it will be less complicated. So these are the investigations I mentioned. Whatever anticoagulation that you're going to start, make sure that you have a full blood count, a creatinine, a PTA, PTT, and an LFT prior to starting anticoagulation. Because once we give that anticoagulation, we can be in serious trouble if we get reports which have been affected by the anticoagulation, and if the patient starts bleeding. Peripartum anticoagulation. At the onset of spontaneous labor, you need to stop anticoagulation. If it is prophylactic low molecular weight heparin, you need to omit about 12 hours prior. If it is therapeutic low molecular weight heparin, omit at least 24 hours prior. IV unfractionated heparin should be stopped 4 to 6 hours prior to the delivery. And if it is therapeutic subcutaneous unfractionated heparin, ideally to be stopped 24 hours prior to either delivery or epidural. Prophylactic unfractionated heparin subcutaneously to be omitted 8 to 10 hours prior. The only indication to use warfarin during pregnancy is if the patient has a mechanical prosthetic heart valve. And if so, this patient also should be changed to heparin at about 36 weeks of gestation. To continue with peripartum anticoagulation, prophylactic low molecular weight heparin should be restarted or can be restarted 6 to 12 hours after delivery, of course, if there's no bleeding. And therapeutic low molecular weight heparin can be restarted 24 hours after delivery. Therapeutic unfractionated heparin also can be started 24 hours after delivery. Low molecular weight heparin should not be given for 4 hours after the use of spinal anesthesia or after the epidural catheter has been removed. And the epidural catheter should not be removed within 12 hours of the most recent injection. A quick word about antiphospholipid antibody syndrome in pregnancy, because we know that pregnancy morbidity is one of the clinical criteria for antiphospholipid antibody syndrome. What I'd like to highlight here mainly is that there are only 3 types of tests which go to uh, uh, diagnose antiphospholipid antibody syndrome. The first is lupus anticoagulant, the second is anticardiolipin antibodies, IgG and IgM, and the third anti-beta 2 glycoprotein 1 antibodies, IgG and IgM. There are private sector hospitals which someone can request for antiphospholipid antibodies, and you get a report saying antiphospholipid antibodies. Now we have to be careful about this because that does not convey any sort of significance in terms of thrombosis. So these are the only 3 tests which you should be thinking about to make when you're thinking about thrombosis. And testing for antiphospholipid antibodies during pregnancy, there's evidence to show that it can be transiently negative or transiently positive in pregnancy. So the recommendation is that you should not check for antiphospholipid antibodies, especially the coagulation one, that is a lupus anticoagulant, during pregnancy. Uh, Again, it is important to note that the lupus anticoagulant, which is a clotting-based test, correlates better with clinical events than do the anticardiolipin and the anti-2 beta glycoprotein 1 tests. You can also get false positive lupus anticoagulant results if the patient is on warfarin, heparin, or even DOACs. Let me hasten to add here that DOACs, or the direct oral anticoagulants which are available in Sri Lanka today, are not to be used in pregnancy as of now. Uh, as I mentioned earlier, it is heparin which is the best anticoagulant to be used during pregnancy, and if at all, warfarin uh, starting from the second trimester in a patient who has mechanical heart valves. Uh, Again, just because your anticardiolipin antibodies and the anti-beta 2 glycoprotein 1 antibodies are positive, that does not signify a high risk of thrombosis. You need to have moderate to high titers of these two tests, IgG or IgM, in order for them to contribute significantly for a prothrombotic state. And when you consider the two tests, IgG and IgM, in both anticardiolipin and beta 2 glycoprotein 1, the IgG test correlates better with clinical events than do the IgM. So therefore, we know that these tests are not available in the state sector. If you are pushed to request a person to do these tests and there are financial restrictions, my suggestion would be that you would go and do the IgG test and not the IgM test. Yes, of course, if both can be done, it's better. But if you have to make a choice, then IgG over IgM for both these tests. Uh, uh, Also, we speak about triple positive tests. Now, if a patient is positive for all three of these tests, then the patient is at a very high risk of developing thrombosis. So we need to make a judgment to see whether these tests, just because they are positive, whether what sort of a risk they contribute to the prothrombotic state when we make an assessment on these patients. What about patients who get pregnant and who come with a positive antiphospholipid antibody test? Now, this is somewhat difficult decision to make because for some reason or the other, the patient has been asked to do a test and they come with a positive lupus anticoagulant test. Then at this point of time, do we give them prophylactic, and this group of patients who have never had a a thrombotic event, or who do not have any pregnancy associated morbidity or mortality? What do we do with these tests? Well, we know that just the fact that the patient has antiphospholipid antibodies, the risk of developing thrombosis is less than 1% per year. However, if the patient has an autoimmune condition like SLE or have other thrombotic risk factors, which I guess pregnancy also can be included into, then this risk of getting thrombosis increases. So therefore, we need to consider the other risk factors as well when we decide whether to anticoagulate this patient during pregnancy or not. Uh, Again, treating these patients in the pregnant state, low molecular weight heparin would be the only therapeutic modality that should be used, not warfarin or not any other anticoagulant. Again, to mention that even in the non-pregnant state, patients with antiphospholipid antibody syndrome should not be treated with DOACs because the evidence does not support that. So in pregnancy, obviously we don't use DOACs, but even in the non-pregnant state, DOACs should not be used at this point of time, although they are much easier to prescribe in this cohort of patients. So uh, I think I'll stop there. I think, but time is up. Time is up, or do we have some time? Time is up. Yes. Huh? Yeah. Okay. Thank you very much for that.
We, in the interest of time, we only will entertain one question which has been recurring from many of our viewers. Will graded stockings prevent deep vein thrombosis in patients who need long immobilization periods, such as in ICU status?
Yeah, I think that's a very good question, because we know that immobilization would cause venous stasis, and what graduated compression stockings do is to sort of push the blood up into the circulation. So yes, using graduated compression stockings and using otherwise pneumatic foot pumps are recommended uh, if you cannot use medical thromboprophylaxis. So the best way to prevent thrombosis would be in a patient who's immobilized would be to use an anticoagulant like low molecular weight heparin at prophylactic doses. However, in the event that that cannot be done, then mechanical resorting to mechanical thromboprophylaxis would be better than not giving one.
We will have another question. The viewer is asking if a patient is having a massive pulmonary embolism seen in the CTPA, almost occluding one main trunk with tachycardia and low saturation, oxygen saturation without shock. What is the role of thrombolysis?
Again, we know that especially in pregnancy, thrombolysis can cause problems to the fetus as well. So if there is, even if there is, I mean, we've seen saddle thrombi. Uh, I think there's the question is something like that. But if there is no compromise and the patient is not in shock, I don't think there is any evidence to say that you should go and do something to that by giving thrombolysis, because we know that thrombolysis can affect the pregnancy outcome. So anticoagulation is and monitoring would be the way forward. Of course, maybe you can alert the team that if the patient does go into decompensation, at that point, yes, then there could be a place to give thrombolysis.
Okay. Thank you, sir, for that excellent presentation. We move ahead with our program, and next we have Dr. Kishara Gunaratna, who is the Honorary Secretary of the College of Physicians, as well as he is a consultant neurologist attached to the Provincial General Hospital, Hambantota. And he will be talking on headaches from a neurological point of view. Over to you, Dr. Kishara.
Thank you very much, Shehan, for that introduction. And I'll start by thanking the CCP for giving me this opportunity to talk to you all. Let's move on. Right. So headache is the most frequent referral for neurologic consultation in the outpatient setting, and that is so worldwide. And I think there's this trepidation that occurs when a pregnant mother does come with a headache, and it's a headache to treat that patient's headache. In other words, and that is because, as you know, that there are what we call primary headaches as well as secondary headaches. Primary headache is where there is no medical condition. The headache is not as a result of a primary medical condition, whereas secondary headache is a condition that is secondary to a medical condition. So there is a propensity for a pregnant mother to actually have devastating secondary headaches. And as physicians, I suppose the first step in evaluating these kind of patients is to actually risk stratify the possibility of a secondary headache occurring in that particular patient. And why is that? That is because these patients they have multiple risk factors to develop secondary headaches. For example, as my previous colleagues who has spoken to you before have highlighted, pregnancy is a hypercoagulable state. There are hormonal changes where there's increase in estrogen and progesterone, and the estrogen progesterone ratio increases over time during pregnancy, as well as these patients are more likely to undergo anesthesia during labor. So these are some of those multiple risk factors that could increase the incidence of secondary headaches during pregnancy. So so if a patient comes to you with a headache, there are three possible scenarios you would encounter. Uh, she would either have a primary headache diagnosed prior to the pregnancy and now coming with her usual headache. That's the first scenario. The second scenario is if it is a patient who has a primary headache and she presents, sorry, she does not have a primary headache, but presents to you with the first severe headache during pregnancy. And the third scenario is patient has a primary headache, but now is coming with a different type of headache. Okay, so these are the three possible scenarios that you would generally encounter in a patient who's pregnant and who's got a headache. And the last two scenarios is where you'd be considering the possibility of an underlying disease or a possibility of a secondary headache disorder. Okay, so when would you suspect a secondary cause? So there are these are the red flags that you would generally consider. The first one is if it's sudden in onset. A thunderclap headache is always, whether you're pregnant or non-pregnant, is almost always a red flag sign that you need to consider the possibility of secondary headache. If the headache is progressive in nature, if the headache changes. The quality of the or the character of the headache changes throughout time. If the headache is refractory to treatment, if it worsens during Valsalva, straining, coughing, or sneezing, or if it worsens with posture, these are all red clinical signs to suggest that we are dealing with a probable secondary cause. On examination, papilledema, peripheral edema, hypertension, focal neurological signs, fever, as well as seizure, are all physical signs that you would look for when you would suspect a secondary cause for headache. So these are the common secondary headaches. As you can see, this is an exhaustive list, right? What I want to highlight in this list is that most of the causes or secondary causes for headaches during pregnancy are often due to some sort of vasculopathy. For example, um, reversible vasoconstriction syndrome, posterior reversible encephalopathy syndrome, um, even cerebral venous thrombosis, all of which are either vasculopathy or as a result of dysfunction in coagulation. Okay, so like we from this point onwards, it will be case histories. I hope you'll be able to respond to the multiple choice questions that are posed. Okay, so let's start with the first case history. This is a 34-year-old pregnant mother, P1C naught, or the first pregnancy. In her first trimester, complains that she started to experience severe throbbing headaches on the right side of her forehead and above the ear. Soon after the headache begins, she finds that she becomes nauseous. Right? When questioned further, the patient goes on to describe how the sunlight from her large window and staring at her screen makes the headache much worse, and sometimes even causes some ringing in her ears. In addition, the patient believes the glare on her computer may be the cause of her headache because she starts to see bright spots on the screen prior to the onset of the headache. Normally, after sleeping an hour or two, the pain subsides. She says she had such headaches in the past prior to her pregnancy. Okay, so what is your diagnosis? Number one, tension type headache, migraine with aura, migraine without aura, CVT, or what we call cerebral venous thrombosis or meningioma. So there's a poll, so you can answer. Okay. Right, so most of you have got migraine with aura, and yeah, so that's absolutely right. Okay, so move on. Okay, so migraine in pregnancy is the commonest type of headache that you would encounter. And you should understand that. So the two types of migraines. I'm not going to go into the clinical characteristics of what migraine is, but this is migraine with aura. What I wanted to highlight is there in this on this slide. So migraine is the commonest. It's about its incidence is around 50 to 60% of all headaches that you would encounter. And what you should know is migraine without aura, which is the commonest type of migraine, actually improves during pregnancy. And improvement or remission is observed in nearly 50% of patients during the first trimester, nearly 80% or a little over 80% in the second trimester, and nearly 90% during the third trimester. The concept is that estrogen is protective towards migraine. So as the pregnancy progresses with the estrogen concentrations in serum, the migraine with the aura basically improves. However, migraine with aura is less likely to improve, which is the case in this particular patient. And new onset migraine with aura and even without aura may occur in the later stages of pregnancy. Okay. Right. Okay. So these are the clinical features or the diagnostic criteria that we would encounter. Which you would consider in making a diagnosis of migraine with aura. And so you can see the criteria. And why is it more prominent in pregnancy? So there are a few theories that are going around with regards to its pathogenesis. There's apparently an increased endothelial reactivity during pregnancy, which might explain the fact that there is an increase, there is this persistence of migraine with aura. Or the other possibility is that the high estrogen to progesterone ratio may lower the threshold for cortical spreading depression, which is the cause for the aura that you would experience, that these patients would experience during pregnancy. Okay, so the second question: what's the treatment option you would choose for these patients? Number one, treatment with acetaminophen, that is paracetamol and metoclopramide. Initiate prophylaxis, whatever type of prophylaxis that's available. Start them on a non-steroidal anti-inflammatory drug, or you can use whether to use injectable therapies such as botulinum, peripheral nerve blocks, trigger point injections, and sphenopalatine ganglion blocks. Okay, let's see what most of you all have answered. Yeah, so most of you all have, 66% of you all have actually answered with the first option, which is correct. Unfortunately, not many of, only 2% have actually considered injectables. Well, I would suggest either one or four. The other two probably are not indicated. Let's discuss this a little bit further. So the safest acute treatments in pregnancy is paracetamol or acetaminophen with metoclopramide. They can be both given enterally or parenterally. Opiates not indicated during pregnancy. Non-steroidal and anti-inflammatory drugs or NSAIDs can be used. However, they can be used during the second trimester for a short period of time. The first trimester generally causes an increased risk of miscarriages, and during the third trimester it causes premature closure of patent ductus arteriosus, which is not what we want. So there is a place of non-steroidal anti-inflammatory drugs if the patient really requires it. However, that would be during the second trimester. Could we use triptans? So there is this growing evidence that triptans are increasingly being found to be safe during pregnancy. Number of cohort studies have found that the malformation risk, the risk of prematurity, spontaneous abortions in a migraine population where they've a dichotomous cohort where the migraineurs were divided into patients who were on triptans and who were not on triptans. They found that there was no increased risk of of any of those risk factors, for example, malformation rates, prematurity, as well as spontaneous abortions. However, compared to a healthy group where the control was compared with a non-migrainous population, there was this increased risk of spontaneous abortions. However, if we actually took away the risk factor of triptans and just compared migraine, the population with migraine as well as the population with, which did not have migraine, there was a increased risk of spontaneous abortion. So there is this growing evidence that triptans may be actually safe to use during pregnancy. Okay, so moving on. Uh, so actually, interventional therapies and non-invasive neurostimulation devices are actually indicated during treatment of pregnancy, and they are quite safe. So in that particular scenario, if you actually suggested treatments such as Botox, peripheral nerve blocks such as occipital nerve blocks, great occipital nerve block, as well as the supraorbital nerve blocks, they're all safe in pregnancy. And if, if you're finding it difficult to treat these migraines with paracetamol and metoclopramide, I suppose the next option would be an injectable option, which is done in this country. The others are, of course, neuromodulation devices, not so much available in this country. The transcutaneous supraorbital nerve stimulator, TMS or transcranial magnetic stimulation, as well as non-invasive vagal VNS or vagal nerve stimulation, all of which are indicated for both treatment as well as prophylaxis in migraine, especially during pregnancy. So there are instances where we may need to consider prophylaxis. However, in the majority, prophylaxis is not indicated because most of the patients that have migraine are the patients without aura, and they actually improve during pregnancy. And you can actually counsel your patients that their migraines are going to improve. However, if you really need to start them on prophylaxis, propranolol would be your first uh, sort of first choice in preventive medication. Your second line would be amitriptyline as well as verapamil. These are all category B drugs. Okay, magnesium supplementation, again used in non-pregnant patients for prophylaxis, can also be used in pregnancy as well. Right. Okay. Non-pharmacological treatment methods are emphasized during pregnancy. You need to identify triggers and such as diet and sleep disturbances, and counsel accordingly. And there is evidence to suggest that uh, biofeedback methods, relaxation techniques, cognitive behavioral therapy, all of which have a effect on the treatment of migraine. Okay, so we'll continue. So the same mother now in her third trimester with a period of amenorrhea of 34. She complains of a holocephalic headache with nausea and vomiting. The headache is unlike the one she normally experiences, so she comes under the third category in our clinical scenarios, which I presented to you before. And she complains of difficulty recognizing objects within her visual field. Headache is unremitting. What is the diagnosis? Is it number one, migraine with aura, CVT, PRESS or posterior reversible encephalopathy syndrome, subarachnoid hemorrhage, and arterial dissection? We call that. All right, okay, so move on. All right, so most of you all have actually got that correct. So it's posterior reversible encephalopathy syndrome, which was actually discussed in the morning. And what would you do next? Perform a PET screen, urgent imaging, start anticoagulation, start acetaminophen and metoclopramide, reassure the patient. Okay, moving on very quickly. So most of the responders have actually suggested urgent imaging. I would agree. However, I think I would do the PET screen first, because that has the if you're suspecting posterior reversible encephalopathy, encephalopath syndrome? Yes, the confirmation is through radiology. So it's a neuroradiological clinical entity which is characterized by, again, an insidious onset of headache, impaired consciousness, visual changes, or blindness, seizures, nausea, vomiting, and focal neurological signs. And two-thirds of patients with headache is the most commonest presentation, which is generally occipital and bilateral, and they generally develop within 12 to 48 hours. And it's very difficult to differentiate between a migraine migraine with aura, and it's associated uh, commonly with eclampsia, preeclampsia and eclampsia during pregnancy. However, can be associated with all the other causes that cause disruption in autoregulation, as was discussed in the morning in our first talk. Okay, so in and these are the general changes that you generally see. I think that was dealt with in the morning. Right. Okay. So the history continues. The patient has had an emergency section following the diagnosis of preeclampsia. She complained of 3 consecutive episodes of spontaneous severe thunderclap headache arising from the back of the neck and nausea. On the 7th day of postpartum, the maximum intensity of the pain was within 1 minute of onset, and headaches lasted for less than 2 hours each time. Her MRI is as follows. So to make things easier, there are these multiple constrictions that you see on the MR angiography. What's your diagnosis? Migraine, reversible cerebral vasoconstriction syndrome, PRESS, CVT, or subarachnoid hemorrhage. So we poll the answers. All right. And most of you have answered correctly with RCVS. This is the typical history that you would generally get with a headache that presents as RCVS, where there will be typically a thunderclap headache, very typical, very similar to subarachnoid hemorrhage. However, and it's precipitated by sexual activity, valsalva maneuvers, and emotion. Often seen in the postpartum period, usually after delivery, a week after delivery, and that the clinical scenario that was presented was actually of an actual patient that presented to us some time ago. And the treatment is to reassure the patient, start them on a vasodilator, which is generally a calcium channel blocker. However, and nimotipine is the drug of choice, as is in subarachnoid hemorrhage. Of course, the evidence to basically support the use of calcium channel blockers is well, generally based on observation studies, right? Okay, normal. A day later, she was complaining of severe holocephalic headache, which was worse on erect posture and better while lying down. She's also complaining of nausea and tinnitus. What is your diagnosis? Intracranial hypertension, intracranial hypertension, migraine, CVT, or subarachnoid hemorrhage. So we poll the answers. All right, okay. And most of you all have got it correct. It's intracranial hypertension as a result of dural leakage. So this is one of the headaches that you need to be looking out for, because most of these patients undergo epidural during labor, and post lumbar puncture headache is a headache which is worse when the patient is erect, and better when the patient lies down. That is the opposite of intracranial hypertension. So this differential diagnosis of secondary headaches during postpartum period is many, and there's a higher risk of postpartum eclampsia, subdural hematoma, especially during delivery, angiopathy, cerebral CVT, as well as pituitary tumor apoplexy, all differential diagnosis that one would have to entertain during the postpartum period. These are the important secondary headaches that I have not discussed. during our previous slides. Pituitary tumors, they because of the vascularity and then the effect of the estrogen and progesterone, there is a chance of the pituitary tumors, which are microadenomas, to enlarge in size, and also there can be a risk of apoplexy as well. Then cerebrovenous thrombosis, as you know, is highest during third trimester as well as postpartum period. And there's also this slight increased risk of idiopathic intracranial hypertension, especially in obese mothers. All right, so those are the secondary headaches that we should be on the lookout for. So in conclusion, migraine is the most common cause of headache during pregnancy. There is growing evidence to support the use of triptans in migraine, and we need to consider important cause of secondary headache, which includes vascular disorders, mainly preeclampsia, reversible leg constriction syndrome, CVT, as well as idiopathic intracranial hypertension. Right, so I think that's all I have to say. I'll be happy to answer any questions if we have time.
Thank you so much, Dr. Kishara, for that presentation. And thank you for turning the tables the other way around with imposing questions on the audience and keeping them lively, I hope. There is a question. What are the indications for of migraine prophylaxis in pregnancy?
So I think it's there isn't a difference in the indications for migraine prophylaxis if you're non-pregnant as well. So, for example, the guidelines suggest that you need to have 4 or more episodes of migraine for you to start on prophylaxis. However, I think the threshold to start prophylaxis should be far higher because of the risk of major congenital malformations associated with prophylaxis, and you need to basically counsel the patient that your migraines are most likely going to improve during the pregnancy. However, if the migraines are affecting the quality of life in those particular patients, yes, I would advocate starting these patients on prophylaxis on a lower dose of prophylaxis. For example, propranolol, we would not go for say 120 milligrams to 300. So the range we would generally use in a non-pregnant patient would be around 120 to 320 milligrams of propranolol. We would generally use the doses that are that most people in this country use for non-pregnant patients, which are subnormal doses, which is around 20 milligram BED or 40 milligram BED for a patient who's got migraine, which is generally used in this country, which is suboptimal in non-pregnant patients.
There's a physician who is, I think, treating patients with related to pregnancies, asking a question. Flunarizine, is it contraindicated in pregnancy?
Yes.
And then there is another question. What is the blood pressure threshold where press is concerned to consider pregnancy in hypertension, pregnancy-induced hypertension? Blood pressure threshold to consider press.
I'm not aware of a blood pressure threshold. It's actually not the height of the blood pressure that actually causes the press. It's actually the blood pressure fluctuations. It's the troughs and the the highs and the lows that actually causes the vasogenic edema. And treatment is basically you need to treat the cause. So in most cases, it's pre-eclampsia and eclampsia.
Thank you so much. And we move on to the next presentation. We have with us Dr. Chandrika Ponnamperuma, consultant cardiologist at the National Hospital of Sri Lanka, And our final talk will be on management of valvular heart disease in pregnancy, the timing and mode of delivery from cardiac point of view. Over to you, Dr. Ponnamperaba.
Thank you very much for giving me this opportunity. You have to do away with the mask for the presentation. So I've been asked to talk today about principles of managing valvular heart disease complicating pregnancy, timing, and mode of delivery from a cardiac point of view. Well, there are some important physiological changes which occur during pregnancy. The plasma volume starts to go up by 6 weeks, and it's about 40 to 50% higher than baseline towards the second trimester, and then it plateaus till delivery. The heart rate starts to go up by about 10 to 20% and remains high for 2 to 5 days after delivery. So does the stroke volume. It increases from about 8 weeks, peaks at about 20 weeks during pregnancy, and returns to baseline only after about 2 weeks postpartum. So this is why pregnancy complicates heart disease, because an already compromised heart sometimes finds it difficult to cope up with these physiological changes. The increase in blood volume, there's a heart rate, increase in heart rate and cardiac output. In addition, there's a reduction in systemic vascular resistance with opening up of the placenta. This causes the systolic blood pressure to fall in early gestation, and diastolic blood pressure is about 10 millimeters mercury below baseline in second trimester. A normal heart will increase the cardiac output to compensate for this drop in vascular resistance. But hearts with fixed cardiac output states like mitral stenosis, aortic stenosis, or hearts which has a reduced ventricular function sometimes find it difficult to cope up with this stress. And there's an increased workload of late pregnancy and delivery, which is obvious. And there's increased coagulability of blood. Certain conditions where, for example, patients who are having prosthetic valves, patients who are having atrial fibrillation, and patients who are having mitral stenosis with dilated left atria, and patients who have low ejection fraction, the risk of thromboembolism is high during pregnancy towards the later stages of pregnancy. And certain drugs which we otherwise use to treat these patients are contraindicated due to fetal toxicity. So these hemodynamic changes lead to increased risk of pulmonary edema and heart failure, increased risk of pulmonary hypertensive crisis. As I mentioned earlier, hypotensive crisis can occur in fixed cardiac output states when the heart is unable to increase the cardiac output for the demand, particularly when the placental circulation opens up. There's increased incidence of thromboembolic events, and there's unmasking of poor cardiac reserve, particularly due to the increased workload of pregnancy. So it's important to have a pre-pregnancy assessment, ideally in all patients, at least in mothers who are known to be at risk, with a good history and assessment of a functional status before pregnancy. When there's any doubt in the history and the functional status before pregnancy, and on clinical examination, if you find anything abnormal like a murmur, echocardiography is indicated. And in patients who have borderline cardiac lesions, or in mothers who have borderline cardiac lesions like moderate aortic stenosis, moderate mitral stenosis, and in patients who have significant cardiac lesions like severe mitral stenosis, severe aortic stenosis, but who don't have any symptoms. They are asymptomatic people with a good exercise tolerance, and exercise test is indicated. And with the exercise test, if the patient could achieve an expected workload of 70% or more, usually they are considered as fit for pregnancy. If there's a drop in blood pressure with exercise, or if there's a drop in saturation, oxygen saturation with exercise, or if they can't tolerate a workload of 70% of expected, they are not fit for pregnancy. Their cardiac status should be reviewed again, and whatever correctable should be corrected before going for pregnancy. So there are certain conditions which are high risk states which are considered contraindications for pregnancy. Pulmonary arterial hypertension of any cause, severe systemic ventricular dysfunction, less than 30% ejection fraction and NYHA class 3 to 4, previous peripartum cardiomyopathy with any residual impairment of left ventricular function, severe mitral stenosis or severe symptomatic aortic stenosis, Marfan syndrome with aorta dilated more than 45 millimeters and aortic dilatation more than 50 millimeters in association with bicuspid aortic valves are considered contraindicated, and also native severe coarctation. If the patient has these conditions, they should undergo correctable surgery or correctable procedures before going in for pregnancy. So if you look at heart disease, overall so far I've been talking about general principles about not only valvular heart disease, general principles governing pregnancy and heart disease. So if you take the, the all heart diseases which we encounter in pregnancy, about 70 to 80% in developed world is due to congenital heart diseases. About 50 to 90% in developing countries, it's due to valvular heart diseases. In Sri Lanka also, we see more valvular heart disease than congenital heart disease going into pregnancy. Coronary artery disease is rare, but it's increasing in frequency with increasing non-communicable diseases in the country. And cardiomyopathies are rare but severe. So my talk today is mainly about valvular heart disease. So we'll restrict to valvular heart disease from now on. So mitral stenosis is the commonest valvular heart disease we see due to rheumatic carditis, right? So pregnant mothers can go into heart failure even with moderate mitral stenosis. About 1/3 of patients who have a mitral valve area of 1.5 square centimeters, that is moderate mitral stenosis, can go into heart failure. In severe mitral stenosis, about 50% of patients can go into heart failure, that is a mitral valve area less than 1 square centimeter. Mortality varies from, maternal mortality varies from about 0 to 3%, prematurity rate of about 20 to 30%, and a UGR rate of about 5 to 20%. And a fetal death rate of about 1 to 5% is associated with mitral stenosis. The risk of a mother with mitral stenosis going into heart failure is higher when she is in an NYHA class of 2 or more, when there's atrial fibrillation, when the pulmonary artery pressure is more than 30 millimeters mercury, and the older the maternal age, the risk of going into heart failure during pregnancy is more. That is due to the associated diastolic dysfunction of the left ventricle, which occurs with age, compromising LV filling. So when you manage these patients, you have to manage them monitor them fairly frequently. There should be at least monthly or bi-monthly follow-up. If the pulmonary artery pressures are high in particular, if pulmonary artery pressure is more than 50 millimeters mercury, you should advocate rest and should start a long-acting beta-1 selective beta blocker. What we commonly use is long-acting metoprolol to control the heart rate for up to about 50 to 60 beats per minute. As you know, when you reduce the heart rate, the diastole prolongs, and that gives more time for the left ventricle to fill through this stenosed mitral valve. Therefore, the cardiac output increases. Therefore, the ideal heart rate you should try to maintain is about 50 to 60 beats per minute. Digoxin can be used if beta blockers are contraindicated, for example, in asthmatics. And diuretics should be added if symptoms persist. Diuretics is not the first choice in these patients because it can cause dehydration and reduced filling of the left ventricle. Beta blockers is the first drug of first choice. If symptoms continue in spite of diuretics, only you add beta blockers. As I told you earlier, they are at higher risk of anticoagulation, higher risk of thromboembolic phenomena. So therefore, there should be a low threshold to anticoagulate, particularly if they are in atrial fibrillation, if there's spontaneous echo contrast seen in echo. This spontaneous echo contrast you see like smoke. Those are microthrombi in the circulation. If there's a low cardiac output or if there's a large left atrium, you should anticoagulate these patients. If the valve is structurally suitable for PTMC, and if there's severe PTMC, the patient should undergo severe mitral stenosis. The patient should undergo percutaneous transseptal mitral commissurotomy after the 20th week. Why we select after the 20th week is then the organogenesis, the radiation injury to the fetus is minimal during that period due to radiation, and also the fetus is still quite lower in the abdomen. It has not come to the upper abdomen. Therefore, the procedure is easier. Patient can lie flat for a longer time during that period, and the complications like the reduced venous return while lying flat are less. So therefore, we try to do these procedures around 20th to 24th, that period of gestation. If the valve is not suitable for PTMC and the patient has severe mitral stenosis, we have and if the mother's life is threatened due to this condition, then we recommend open valvotomy or mitral valve replacement. This is only for mothers who go into pulmonary edema or heart failure with mitral stenosis. Otherwise, we try to manage them medically. Regarding delivery of these patients, vaginal delivery is preferred if they are in NYHA class 1 or 2. Lower segment cesarean section if they are in class 3 or 4 heart failure, and if the valve is not suitable for PTMC or if PTMC has failed. Only those patients go for cesarean section. There are a few issues with vaginal delivery which need to be dealt with. You have to, during vaginal delivery, the patient gets pain and gets tachycardia. This should be minimized. Therefore, epidural anesthesia is recommended to eliminate the pain as much as possible so that the tachycardia will not occur. Work of labor should be minimized. Therefore, we recommend assisting the second stage of labor. And there is when the placenta empties into the circulation, there is a volume overload which occurs in the second stage of labor. To reduce the effects of that, we recommend giving a bolus of IV furosemide 40 milligrams in the second stage of labor. So we recommend delivering under epidural anesthesia with assisted second stage, and also recommend to give furosemide IV 40 milligrams during the second stage of labor. Lower segment cesarean section in mothers with mitral stenosis, when done, it's rarely done. We need to avoid excessive vasodilatation during anesthesia. Therefore, what is generally used is a combined spinal and epidural anesthesia. Spinal alone is not used due to this problem of vasodilatation. And also we recommend meticulous fluid balance. We have to avoid fluid overload. Then we come into aortic stenosis. Again, like mitral stenosis, aortic stenosis also is a fixed cardiac output state, therefore should be managed carefully during pregnancy. It could be bicuspid or rheumatic. In our part of the world, rheumatic is commoner. And the outcome depends on three things. One is the severity of aortic stenosis. Second thing is symptoms the patient has at baseline before getting pregnant, and the LV function. Asymptomatic patients with moderate and severe aortic stenosis with a normal LV function, that is LV function more than 50%, ejection fraction more than 50%, we recommend a pre-pregnancy exercise stress test. That's a treadmill test, exercise treadmill test. If the patient does the treadmill test well, achieving 70% of workload with a normal blood pressure and heart rate response, the patient can be predicted to tolerate the pregnancy well, and pregnancy is recommended. That is in moderate and severe aortic stenosis with normal LV function who are asymptomatic. Severe aortic stenosis with symptoms or reduced LV function, they need to undergo aortic valve replacement surgery, before pregnancy. So if the patient has severe aortic stenosis with symptoms or with reduced LV function, pregnancy should not be recommended before aortic valve replacement. They should undergo aortic valve replacement first and then go for pregnancy. If these patients are asymptomatic, then you recommend a treadmill test to see how well, to predict how well they will tolerate pregnancy. So these patients also need monthly or bi-monthly cardiographic follow-up. They need rest and medical therapy for heart failure. Again, beta blockers, long-acting beta blockers, beta-1 selective beta blockers are recommended. If they have severe symptomatic aortic stenosis which is not responding to medical therapy, balloon valvuloplasty is recommended if the valve is non-calcific. That is mainly you see in patients with bicuspid valves. Here in our patients who have rheumatic valves, most of them have very calcific valves, which makes the balloon aortic valvuloplasty very risky. So if the patients have severe symptomatic aortic stenosis with a valve not suitable for valvuloplasty, balloon aortic valvuloplasty, we recommend early cesarean segment section, LSCS, in preparation for aortic valve replacement. Early because as soon as the fetus is viable, we recommend to take the fetus out. Usually we recommended doing it in a cardiothoracic theater, so that if the patient goes into cardiogenic shock during surgery, they can go on pump. The pump is this heart lung pump. So and do the valve surgery at the same sitting, so that the mother's life will be saved. If this aortic stenosis is not severe, we recommend vaginal delivery. So the difficult customers are the stenosis of mitral and aortic valves. So in regurgitation, in mitral and aortic regurgitation, decreased systemic resistance reduces regurgitant volume, LV dysfunction. Decreased systemic resistance reduces the regurgitant volume. Therefore, it helps the heart. So they feel better. LV dysfunction and acute severe regurgitation are poorly tolerated even though. So if the patient didn't have much aortic regurgitation and mitral regurgitation, if they develop severe regurgitation during pregnancy, they tolerate that poor due to the increased volume overload and all that. So the fluid overload should be medically managed, and therapy refractory heart failure should undergo valve surgery, aortic or mitral. Symptomatic patients, if they are class 2 or less, can undergo vaginal delivery with epidural anesthesia and shortened second stage as earlier. Pulmonary stenosis is usually well tolerated. Severe symptomatic pulmonary stenosis will need balloon valvuloplasty. Otherwise, even severe pulmonary stenosis, if not symptomatic, doesn't need valvuloplasty. So the next important subtopic on valvular heart disease is mechanical valve prosthesis and anticoagulation. This has to be understood properly because this is a preventable common cause of maternal death in Sri Lanka. So warfarin is the best for valves. With warfarin alone given in all 3 trimesters, there's a thrombosis rate is 3.9%. and a mortality of about 2%. If unfractionated heparin is given in all 3 trimesters, in second and third trimester, sorry, unfractionated heparin in the first trimester and warfarin in second and third trimester, the thrombosis rate will go up to 9.2% and the mortality rate will double to 4%. If unfractionated heparin is given in all 3 trimesters, the thrombosis rate will go up to 33% and the mortality rate will go up to 15%. If low molecular weight heparin is used in all 3 trimesters, the thrombosis rate will go up to 9%. So the best for the valve is warfarin. Let's see what is best for the fetus. With a warfarin dose of less than 5 milligrams, there's a risk of embryopathy of 2.6%. When the warfarin dose is more than 5 milligrams, the risk of embryopathy goes up to about 8%. This is because warfarin crosses the placenta, but the heparins, low molecular weight and unfractionated, does not cross the placenta. Therefore, for the valve, warfarin is good. For the fetus, heparin is good. To strike a balance, what is recommended is if oral anticoagulation should be continued until pregnancy is achieved. There's no doubt about that. If the warfarin dose is less than 5 milligrams, we recommend continuing it throughout pregnancy because it has the lowest risk on the valve, and for the embryopathy, the risk is only about 2.6%. We recommend switching to low molecular weight heparin or unfractionated heparin from 6 to 12 weeks of pregnancy if warfarin dose is more than 5 milligrams. Effect of more than 5 milligrams. Then all anticoagulants during pregnancy are very unpredictable. Therefore, should be able to monitor. We should not use enoxaparin unless we can monitor factor 10A levels. That is a big mistake people do. They put on enoxaparin and end up getting valve thrombosis without monitoring. So during delivery, again, as I said earlier, warfarin crosses the placenta and can cause a coagulopathy in the fetus. Therefore, if the patient is already on warfarin, patient should not undergo vaginal delivery because the fetus is going to get a ICH due to that. Therefore, for planned vaginal delivery, warfarin should be stopped at 36 weeks, started on heparin or enoxaparin if monitoring is possible, otherwise unfractionated heparin, and go for a planned vaginal delivery. If warfarin is continued due to high risk of thrombosis, patient should not undergo vaginal delivery, should undergo cesarean section. If patient has to undergo emergency section, if patient goes into labor, unplanned labor while on warfarin, it is recommended to do emergency section without letting the labor proceed. In summary, pregnancy in the high-risk population should be considered a failure in the primary healthcare system. Women with valvular heart disease may tolerate pregnancy well. Therefore, it's not contraindicated for everybody. Follow-up and mode of delivery need to be individualized. They should be properly assessed before pregnancy and appropriate recommendations should be made. Percutaneous interventions are indicated mainly for symptomatic severe mitral stenosis and severe aortic stenosis. Indications for surgical interventions during pregnancy are rare. Anticoagulation with warfarin throughout the pregnancy is safe when the dose is less than 5 milligrams. Low molecular weight heparin or unfractionated heparin can be used instead of warfarin in the first trimester if warfarin dose is more than 5 milligrams. Low molecular weight heparin should not be used if factor 10A levels cannot be monitored. Should appreciate the hemodynamic changes of pregnancy and labor when managing valvular heart disease in pregnancy. Thank you.
Thank you, Dr. Kona Perunda, for the we have some questions. If a pregnant patient with heart failure has postpartum hemorrhage and goes into shock, how is the management different from those than those without heart failure? What can you tell us about it?
Can you repeat the question?
If a pregnant patient with heart failure has postpartum hemorrhage and goes into cardiac shock, How is the management different from those who don't have heart failure?
Well, it needs very meticulous hemodynamic monitoring during this period. That is the key, because presence of heart failure, you should the volume status should be managed as accurately as possible. Therefore, you need intra-arterial blood pressure monitoring as well as CVP monitoring is essential. And fluid resuscitation should be done to maintain a CVP around 10-12 CVP should try to manage, and should try to keep the hemoglobin around at least around 8. The minimum should not allow hemoglobin to drop around 8. Then the rest of the management will depend on what actual cardiac condition the patient has.
There's another question. Is there are there any contraindications for breastfeeding in peripartum cardiomyopathy?
Yes, there is a contraindication for breastfeeding in peripartum cardiomyopathy. Peripartum cardiomyopathy is a condition with a significant mortality. Therefore, you should treat it with optimum medications for heart failure. So one reason why breastfeeding becomes contraindicated because of the drugs, because we have to give ACE inhibitors, we have to give spironolactone, drugs which are generally contraindicated in breastfeeding. Then the other thing is to reduce the maternal workload. The third thing is prolactin is considered as one of the pathways which is causing heart. That's not proven, but there are studies which has shown bromocriptine helps in peripartum cardiomyopathy. Therefore, one other reason, a speculated reason, is to reduce the prolactin secretion during this period.
Thank you, Dr. Pannamperuma, for that presentation. And now we come to a halt of today's program, which is the last of the series of specialty medicine organized by the Ceylon College of Physicians. Lastly, I would like to invite all of you for the CCP annual conference, which will be held in collaboration with the Royal College of Physicians. And we hope to have it as a hybrid conference as of yet. And we will be having the pre-congress sessions on the 19th, where there will be 2 workshops. One workshop will be on research methodology, I think, which will be very much beneficial for our trainees. And the other workshop will be on frailty and sarcopenia in older adults. This will be in collaboration with the Sri Lankan Association of Geriatric Medicine. And the main conference will be held on the 20th and the 21st. And there will be many teaching capsules. There will be small feeds, and there will be various symposia extending from cardiology, neurology, medical humanities, rheumatology, gastro, dreaded disease COVID-19, metabolic medicine, emergency medicine, pulmonology, and nephrology, and so on and so forth. So we earnestly welcome you, invite you to join this program, which will be held at Hotel Galadari in the month of November. Thank you so much for joining with us, and we thank again all our speakers for a wonderful time of enlightenment. We wish you all the very best. Thank you.